Good day, everyone. We are going to continue our respiratory discussion today, and we are going to start with acute respiratory failure. So, one of the key components of acute respiratory failure is hypoxemia, and it's usually defined by arterial oxygen level that is less than 60 millimeter of mercury. So, and there are different causes of hypoxemia. It could be from ventilation perfusion mismatch, right to left shunt hypoventilation, at or somebody breathing at very high altitude, or even any cause of diffusion impairment. Okay, so before I start, there was something I remember that I want to correct about yesterday's lecture, and that was where we were talking about compliance in COPD. So I'll just, because we are still going to be needing it as we proceed further in our discussion today. So yesterday I was talking about the elastic fibers surrounding the alveoli, and I said these elastic fibers are being destroyed by the neutrophil elastase, and the enzyme that helps to protect these alveoli elastic fibers from being destroyed by the neutrophilic elastase is the alpha-1 antitrypsin. And anybody that lacks alpha-1 antitrypsin would have the neutrophilic elastase coming in to destroy the elastic fibers. So actually, the function of the elastic fibers is to allow for elastic recoil, not for expansion that I mistakenly said. I was supposed to correct myself that day, but I forgot. So it is not to expand, but its basic function is to allow for elastic recoil, which is to bring the alveoli inwards so that we can force out air during expiration. So with elastic recoil of the lungs, of the alveoli, we can have air being pushed out of the lungs. So that is why expiration is said to be a passive process. You don't need to do anything. Why? Because the elastic fibers surrounding the alveoli, they are there to undergo elastic recoil, which is this part coming towards this side and this part coming towards this side, so that they can squeeze in on the hair and they can push it out like that. So that means that if somebody has COPD, specifically emphysema, and there's destruction of the elastic fibers that are outside, the person is going to find it difficult to push out hair because the alveoli, in a way, they are going to be flabby. So that means that if air comes in easily, they'll be able to stretch. So that means that because there's nothing to allow for elastic recoil again, so they are flabby and they can move outwards easily, but they cannot move inwards. So that is why if you check the compliance changes in somebody with COPD, specifically emphysema, it is increased. The same thing happens in aging. In aging, you have gradual loss of the elastic fibers. So compliance is increased because they can easily distend, but they cannot recoil on each other. Please, do we understand this explanation? Is it clear to us?
Not so clear, sir.
Okay. I just want us to just picture it like this is the alveoli. The function of the elastic fibers is to allow the alveoli to squeeze together. Just imagine you are squeezing this alveoli like this. If you want to squeeze it, you are applying the force in this direction. One here, another one is coming like this. That is like squeezing. Do we understand that? Is that clear to us? So
Yes, I can understand.
yes, so that is elastic recoil. You are recoiling, you are squeezing on something so that you can, if you recoil this thing, there won't be any space for hair to stay. So hair will have to move out. That is expiration. That is what happens during expiration. Elastic recoil of the lungs. Now, what is compliance? Compliance is not elastic recoil. Compliance is the ability of something to extend when air comes in. Now, let me create an hypothetical situation for us. If something has a very high elastic recoil, if we put in air to that stuff, do we think it's going to distend? Is it going to distend or it's going to move inwards? So if it's distending, it's moving outwards like this. It's going to stretch like outwards like this. That is distension, and that is otherwise known as compliance. Because if something is compliant, when you add air, it can distend. If something is not compliant, if you add air to it, it will not distend. So it means that anything that has elastic recoil, they will not distend because they will squeeze on that thing to push it out. But if there's no elastic coil, it means that there's space, there's enough room for air to come in, and the alveoli is going to move outwards. Like it will, what's the word to use? It will like expand to accommodate what you are bringing. But if something has a lot of elastic recoil, it cannot expand. It will squeeze on itself to push that thing back. Doc, do you get what I'm trying to say?
Yes, sir. Thank you. Yeah, got
So
it
so
now.
that is the
Thank you
reason
so much.
why, yes. So that's the reason why COPD, they have a increased compliance. We don't need to do rushing in the exam. In the exam, once you see the question, just try to take your time to think about it. What will happen before you pick your answer? You don't need to rush at all, at all. So, now back to acute respiratory failure. We have talked about hypoxemia to be a key part, and PaO2 is less than 60. So once it's less than 60, so somebody is hypoxemic. Now, what are the causes of hypoxemia? It could be due to ventilation perfusion mismatch. It could be due to a right to left shunt. It could be due to hypoventilation. It could be due to breathing at high altitude, which have low inspired oxygen content, or it could be due to diffusion impairment. We are going to take them one by one so that we can understand the way they affect um, the partial pressure of oxygen. So mind you, I have to say that hypoxemia is defined as partial pressure of oxygen, the P small a O2 less than 60, not P big A, because the P big A O2 is talking about the pressure of oxygen in the alveoli. This one. This is the one in the alveoli. The one we are looking at is the one in the blood, which is P small a O2. So what are the features of somebody that have, hypoxemia? So definitely oxygen saturation might be low. There's cyanosis, there is blue chest pain, depending on the cause. If it's from pneumonia, from pulmonary embolism, they can have pleuritic chest pain. And if it becomes very severe, the person is going to start experiencing hot heart sensorium. So what is the best initial test? The best initial test to even make diagnosis of hypoxemia is what? To do the arterial blood gas. Arterial blood gas. So that is where you are going to say that the PaO2 is going to be less than 60. So you can say that, oh, this person likely have hypoxemia. But to evaluate for the cause of hypoxemia, to further narrow it down, you need to calculate what we call the AA gradient. The big A minus small a. That is what we call the A gradient. I know that Dr. Babarinde will have taught us in our respiratory, so it's not something that is new to us. But how do we can calculate the small a, right? We can get the small a by measuring the PaO2 from our arterial blood gas. But we cannot get the big A from there. So we need to, slot in some values in a formula to get the P big A O2. Because the difference between the P big A O2 and the P small a O2 is what we call the AA gradient. So that gradient can give us an idea of the likely cause of the hypoxemia. So I'll just be using it to get to a part, I'll just be saying capital A, small a, so that it will be easy for us. So we already know when I say small a, that is partial pressure of oxygen in the blood. Big A, partial pressure of oxygen in the alveoli. So what is the formula for the big A? So the formula is this that I have here. So the atmospheric pressure minus the pressure of water times the FiO2, which is the fraction of inspired air that is containing oxygen, minus the PaCO2 over the respiratory quotient. We don't need to memorize the formula. Nobody's going to ask us. It's just a way to just explain, what is happening. Now, the way me I get it is that, I assume that what we have here is the total pressure of air that is coming into the lungs. The total pressure of air that is coming into the lungs is this, what I've encircled here, which is atmospheric pressure minus pressure of water times FiO2. But I want to know the one that is coming to the alveoli, that is oxygen. So it makes sense for me to just say that, okay, what is the total pressure of air that is even coming to the lungs? What is the total one that is coming to the lung? What is total? Okay, this is it. Now, let me remove the one that is constituted by CO2 from it, because the two major constituents of air is CO2 and oxygen. So if I know the total, I can know oxygen by removing CO2 from it. That's a simple logical way to remember it. So then we subtract PCO2 from it over the respiratory quotient. That is it. Now, what is a value that is expressed by this formula? So that brings us to 150. So everything here that we are seeing here is 150. So why do we need to be cramming the formula? So it means that PaO2 equals 150, which is like the total pressure of air that is coming to the lungs, minus PaCO2 over respiratory quotient. So that is going to give us the pressure of oxygen in the alveoli. It is as simple as that. Now, how am I going to get the PaCO2? I'm going to get it from my arterial blood gas. It's part of what I can measure in my arterial blood gas. So once I get it, I put it in here. The respiratory quotient is 0.8. So 0.8 over, whatever I get here, minus 150. That is going to give me my big A. So once I get my big A, I just subtract it from what I measured here for my small a, and I get my A gradient. Is it clear to us?
No.
Yes.
Some people are still confused. So what part is not clear? So that I will know.
How did you arrive at
How do I what?
0.8?
Sorry, I can't hear you at all.
How did you arrive at 0.8?
0.8 is the value for the respiratory quotient. This value here, you see, this is PaCO2 over respiratory quotient is a constant 0.8. Do you get it? Hello? Okay.
Yes,
So,
I think she's raising her hand. Like, yes, yeah.
okay, that's fine. So now, when we are done with that, we can now do X-ray. So that's going to give us the value. So we can say the value is high or it is normal, depending on when we compare it to a particular value. So what value are we comparing it with? So we are comparing it with this value. So ideally, the normal gradient should be whatever we get over 4 plus 4. So the age of the person over 4 plus 4. So if somebody is 40 years, so the normal age gradient we expect for that person should be 40 over 4 plus 4. So that is going to be like 14. It should not be, we cannot use age more than 14. So if somebody is 60 years, we are still going to use the value for 40. It is 40 that we are still going to put in the age. So the normal AA gradient for somebody is their age over 4 plus 4. So somebody that is 50 years, we cannot go beyond 40. So it's still 40 that we put in here. But if somebody is 30, we'll put in 30. So 30 over 4, or let's say 28. Somebody is 28 years. So 28 over 4, that's 7 plus 4, that is 11. So that means that if we calculate the A gradient, if it's more than 11, so that is high A gradient. If it's 11 or less, that's going to be normal A gradient. So that is how we determine if the A gradient is high or it is normal. So the best next step is to do X-ray. to find out what is the underlying cause. So to further, nail that diagnosis. So definitely it can be pneumonia. We know what we are going to see. If it's pneumonia, we can see the opacities, atelectasis, homogeneous opacity due to lung collapse. Pleural effusion, we know what we are going to see, the meniscal sign. Pneumothorax, we are going to see the hyperlucency on the X-ray. So now let's look at the algorithm. So we do our ABG, we're able to see that the PaO2 is less than 60. We know that there's hypoxemia. So the next thing is to calculate the A gradient to be able to narrow the cause of that hypoxemia. So when we calculate the A gradient, we can get two things. Either it is increased or it is normal, depending on the value that we calculate. So if it's increased, so the next thing is to try and give oxygen. If it's increased, try and give oxygen. So for people with cardiac problems, if you do not take anything from this lecture, please know that one. For people with cardiac problem, either the person is having a congenital heart disease or something, if you give them oxygen, it will not improve the hypoxemia. It will not. Or if somebody has a shunt, so shunt means that if this is a lung, this is the respiratory membrane, and this is blood, because that's the way it works. This is the alveoli here, this is the respiratory membrane, and this is blood flowing here. The idea thing that oxygen is going to move downwards across the respiratory membrane into the blood. Now, if somebody has a shunt process, it means that oxygen cannot leave this lung, either because the lung is totally collapsed or there's a total consolidation of that lung, so that oxygen cannot leave. It means that blood that is flowing across that lungs is shunted. It means it's just flowing. There's no oxygen diffusing towards it. That is what we call shunting. So that can occur in people with ARDS. It can occur with people with massive atelectasis. So all those kind of people, there's nothing you can do. If you give them 1 million oxygen, nothing will move because there's no lung to function. So in that situation, the PaO2 is not going to be corrected with oxygen. So people with intracardiac shunt, like a right to left shunt, maybe the person is having TOF, or just think about all those tricuspid atresia and all those things, those right to left guys. Give oxygen, it will not correct. Or when there's a vascular shunt, like massive atelectasis, massive pneumothorax, massive lung collapse, and all those things, ARDS, they are not going to respond to oxygen. But if it responds to oxygen, so it's either due to like VQ mismatch, and there are so many things that can cause VQ mismatch. So many things. Either the person is having asthma, COPD, interstitial lung disease, atelectasis that is not massive, like pneumonia, pulmonary edema that is not bilateral, pulmonary vascular disease like a PE. So all these ones, they are going to cause VQ mismatch. And VQ mismatch just talks about V over Q, in which V is talking about the ventilation and Q is talking about blood supply. So ideally, you should have a balance. Ventilation, air that is coming from the alveoli, and Q, which is blood flow. Blood should also be flowing to that lung so that they can receive the oxygen that is moving from the alveoli. And they can also move CO2 from that blood into the alveoli. That is VQ matching. But in some situation, you have something that is going to be impairing ventilation. Either the person is having a pneumonia or the person is having asthma, that the person cannot take air into the blood because there's a problem with the lung. Or there could be a problem with the blood flow. Example, the person is having a PE. If there's a PE, there's occlusion of the blood vessels, so there's no way blood can flow. So there's going to be a VQ mismatch. So I see vascular shunting as a severe form of VQ mismatch. So if somebody have total lung collapse, so that means that ventilation in that kind of person is zero. That is zero. So that is what you call shunting. So that kind of person, oxygen cannot do anything. So, but if the person is just having like maybe small lobar pneumonia or something that is not affecting the entire lung, and there's still like a little room for ventilation to happen, so you are going to get a VQ mismatch. Ventilation will just drop relative to the blood flow. So you call that VQ mismatch. It can also cause hypoxemia. So that's that about the increased gradient. But once the gradient is normal, two things should come to your mind. Now, The reason why all these ones, they cause the gradient to be increased, let me explain it. So if we look at the formula, increased gradient is A minus A, right? That is going to be the gradient. That is the gradient. So if it's increased, we can say that it is increased because small a is low. Do you understand that? Small a is low compared to big A. Does it make sense to us? Like for us to get a value that is high, it means that small a drops relative to A, right? Do we get that?
Yes.
So now let us look for conditions that can drop small a that will not affect alveoli. So that's the way to just do it. So that means that let us look at conditions that can affect diffusion of oxygen to the blood. But that stuff is not affecting how oxygen gets into the lung. So if you look at all these things that we have talked about, these ones will not stop oxygen from entering the lung. Asthma will not stop oxygen from entering the lung. In as much as the person can still breathe, they will still be able to get air in that lung. So in them, A is going to be normal because this is just the alveolar pressure. But because of some pathologies, COPD, where the respiratory membrane is compromised, there's alveolar collapse. There's no way they can get air into the blood. So that means that small A will be decreased. Interstitial lung disease too, the same thing. They cannot get air into the lung because of the fibrosis that's happening there. There's no way air can leave the lung to go to the blood because when there's fibrosis, the respiratory membrane is compromised. There's no way air can get into the blood. So people with atelectasis too, pneumonia, pulmonary vascular disease, there's obstruction of the blood vessel. So there's no way oxygen can get into the blood. So all these ones will just cause a VQ mismatch. But the ones that will affect big A are something that is affecting the atmosphere. Either you are breathing oxygen at a very high altitude that has a very low atmospheric pressure, or the person is hypoventilating. You are not even taking oxygen because you're hypoventilating. How do you want to take oxygen into the lung? You cannot because you're hypoventilating. So in these two scenarios, A is going to drop. Big A is going to drop. And when big A drops, definitely it's going to drop small a. Don't forget, it is big A that is later translating to A because it is the air in the alveoli that will eventually diffuse into the blood to constitute small a. So in any situation that there's a drop in big A, there will definitely be a drop in small a. So that means that if you calculate the gradient in that kind of situation, it will be normal. Because if the normal value is like 20 for big A, and the value for small a is 10 millimeter of mercury, and the difference is 10. So if there's a drop in big A by 5 and it drops to 15, that 5 decrease is also going to be translating to the small a, and it will drop by 5 too. So 15 minus 5 is still 10. So anything that affects big A will just cause a normal A gradient because both of them will be affected. But for the increased one, they are only affecting the small a. So that's why the gradient is increased. So what are the things that can cause normal AA gradient? Either you are breathing at a very high altitude or you are hyperventilating. Don't forget that. You are breathing at high altitude or you are hyperventilating. How will you now separate between them? Just go and calculate your PaCO2. Because somebody that is hypoventilating, they will not be able to take out CO2 from the lungs, from the blood into the lungs. So it means that the level of the PaCO2 is going to be increased. So once we do our ABG and we are getting our PaCO2 with it, and we notice that it is increased, we know that that is hypoventilation causing the hypoxemia. But for people with breathing in high altitude, their PaCO2 is not going to be increased. It's not going to be increased because these guys are even like trying to get him oxygen, they're hyperventilating. So PaCO2 may even drop. So, but once you see that PaCO2 is increased, that is hypoventilation. So you just look at all the causes of hypoventilation. Is the person on drugs? Is he having obesity hypoventilation syndrome? Does the person have a muscle paralysis like maybe Guillain-Barré, ALS, or myasthenia gravis? Of course, that's going to be myasthenia crisis. Or maybe the person is just having stroke, as there's a drop in respiratory drive. So all these ones will cause hypoventilation. So that's the algorithm to follow when you want to determine the cause of hypoxemia. So how do we treat? Just look for the underlying etiology by doing all these algorithms. So once you have done all these algorithms, if you get to VQ mismatch, try to do a chest X-ray. It's going to show you any one of these that is causing the problem. You know, if you give oxygen, it's not working, you definitely know that you have to evaluate for a cardiac cause. Or you also do X-ray. If it's going to be a massive atelectasis, you will see it on the X-ray and you know what to do next. Administer oxygen too, especially if the gay ingredient is increased. Give oxygen to see what is the cause. You know, but most of the time you give oxygen all through, you know, because they have to be on oxygen, because the problem is hypoxemia. There's low oxygen, but the oxygen can tell you what is also happening, because in some people they will not respond to the oxygen that you are giving. So increase oxygenation parameters if the patient is on mechanical ventilation, and I'm going to talk about that shortly. So now there are different parameters you can adjust on mechanical ventilation. We are going to break down mechanical ventilation shortly, and we need to know some parameters that we can adjust and what this adjustment is going to cause. So from our respiratory, from step 1, you see, that is why step 1 knowledge is important, because if step 1 knowledge is not there, it will be very difficult to be explaining step 2. From our step 1, we have said it already that minute ventilation equals the respiratory rate times the tidal volume. The respiratory rate times the tidal volume. So this is going to, if we increase respiratory rate, minute ventilation is going to increase. If we increase tidal volume, minute ventilation is going to increase. So it is as simple as that. But for oxygenation, to increase oxygenation, so don't confuse the two. There's a difference between ventilation and oxygenation. So this one, ventilation usually will help you to adjust CO2, because once you hyperventilate, you take out CO2. Once you hyperventilate, PCO2 is going to increase. Don't forget that. So if they give you any question in step 2, USMLE, and they are telling you something about PCO2 to adjust it, what you are going to pick is anything that relates to mechanical ventilation, to minute ventilation. Either you adjust the respiratory rate or you adjust the tidal volume. Don't ever forget it. When it comes to PCO2, PaCO2, you want to adjust it, you have to go and adjust ventilation. If you want to adjust oxygenation, you want to adjust this thing that we are going to talk about now, which is your FiO2 or your PEEP. So if you increase FiO2, oxygenation is going to increase, because FiO2 is just basically the volume of air that you're breathing. What fraction of that air is oxygen? So if you are breathing in 100% air, if 21% of it is oxygen, so that means that the FiO2 is 21%. So FiO2 is a fraction of inspired air that is constituted by oxygen. So if you increase it, you increase oxygenation. Most of the time, we don't want to get it above 60. Once you get it above 60, the person is at a risk of oxygen toxicity. That's another step too fat. You don't want to forget. Don't take it above 60. Now, if you have adjusted FiO2 to the limit and you don't want to go beyond that, what are you going to adjust? You can adjust your PEEP. And we are going to talk about PEEP shortly. So PEEP is just the pressure that is remaining in the alveoli that keeps the alveoli open. Anybody wants to relate PEEP to volume? What's now going to be the volume equivalent of PEEP? Anybody? Can anybody understand what I'm trying to ask? If we say that the pressure that is remaining in the lungs at the expiration, after expiration, that is keeping it open is PEEP. What is the volume in that lung called? Anybody?
Residual.
Residual volume.
Residual volume.
So just look at residual volume and PEEP like the same thing. That is preventing the lungs from collapsing at the end of expiration. That is PEEP. So that means that if we have a higher PEEP, we are going to be able to open up more alveoli, so that there will be enough room for oxygenation to happen. Very, very important. So in hypercapnic patients, we have said this. In hypercapnic patients, just increase ventilation by increasing respiratory rate or increasing tidal volume so that you can increase CO2 exchange. It is as simple as that. There's no, like, it is as basic as that. That is it. And that's how you are going to see it in your exam. They will just paint one scenario and like that. And they will ask you, what are you going to adjust? Okay, somebody wants to ask a question.
So what I want to understand is, so for ventilation, you relate it to the CO2?
Yes.
Okay.
Yes.
Okay.
Then for oxygen, you relate it to FiO2 and PEEP.
Okay. All right. Thank you.
So moving on to ARDS. So ARDS is just a condition in which somebody is having respiratory failure with refractory hypoxemia. Don't forget, we have said it. ARDS is the cause of what? Shunt. Somebody that have ARDS, if you give them oxygen, it will not respond. So that is why they have the term refractory hypoxemia. Refractory hypoxemia. Most of the time, they will benefit from mechanical ventilation. You need to place this guy on mechanical ventilation. What is going to happen to their compliance? Now, we don't need to cram this. Let me show you how you remember. So we ask ourselves, what is the pathophysiology of ARDS? So people with ARDS, they just have maybe sepsis or something that is destroying the endothelial lining of the vessels. This is the respiratory membrane here. This is blood here. So now, this is the alveoli here. Please, I want us to be used to this image. I'll be using this illustration a lot. Alveoli, respiratory membrane, and blood vessel. Now, in ARDS, there's an insult to the lungs. Maybe the person has a sepsis, or the person has like aspiration, or the person drowned, or the person has trauma, and there's damage to the blood vessel, the endothelial lining. What is going to happen? There's going to be extravasation of fluid moving upwards across that damaged endothelium into the alveoli. So there's going to be like congestion in the alveoli bilaterally. ARDS is not unilateral. That is why it is bad. Both of the lungs will suffer the same damage. So that is that. Now, when that happens, that fluid is going to wash out what we call surfactant. So we know that there are surfactants in the lungs. And what surfactant does is to help us reduce surface tension. Now, I want us to picture surface tension as a force that acts like elastic recoil. Now, what is the direction that elastic recoil is acting? Is it inward or outward? Anybody?
Outward.
Inward. Inward. So it is, squeezing the lungs inward like this. So that is exactly the direction where surface tension are. Don't allow anybody to bubble us with surface tension and be blowing physics. That's just all we need to know. Surface tension is just a force that is squeezing, the lungs internally, inwards. Now, surfactant is like that group of chemicals that have been produced by the type 2 pneumocyte to help us reduce that surface tension. So it means that somebody with ARDS, they don't have any surfactant again because the fluid that is entering the lungs due to damage to the endothelial lining has washed out all the surfactants. So that means that there's a high tendency for the lungs to move internally like this, which is direction of what? Surface tension. So what do we think is going to happen to the compliance in that situation? Is it going to be increased or decreased? Anybody?
Decreased.
It's going to be decreased. So that is why people with ARDS, they have a decreased lung compliance. They are going to have a non-cardiogenic pulmonary edema. Don't forget, we have said it, that fluid is moving into the lung. So definitely there's going to be pulmonary edema, but it's going to be non-cardiogenic. That's a very, very important distinction. If you listen to this person now, you might not be hearing S3. You might not be seeing leg swelling. So if we measure the PCWP, which is a pulmonary capillary wedge pressure, which gives us a reflection of the left atrial pressure, it is going to be normal in them. But someone that has heart failure, we expect the PCWP to be what? To be elevated. So we see somebody that's having feature of pulmonary edema and PCWP is normal. Don't think of heart failure. It's a possibility that the person is having ARDS. No. They are going to have a PaO2 over FiO2 ratio less than 300. This makes sense because definitely what do we expect? If somebody is having problem with the lungs, like this congestion, definitely there won't be any space. There's no way oxygen in this lung can even move across the respiratory membrane to get into the blood. So PaO2 is going to drop. But do we think the FiO2 is going to drop? Because FiO2 is just the amount of inspired air that the person is taking in that is constituted by oxygen, right? Do we get that? So that one is not really affected by the process. So that is why people with ARDS, the PaO2 over FiO2 ratio is going to be less than 300. So you don't need to cram it. You expect it to be less because the one that will drop is what? The PaO2, not your FiO2. In fact, you might even need to increase FiO2 to increase oxygenation. And the more you are increasing FiO2 and the more PaO2 is decreasing, the ratio is also going to be decreasing. So the severity of the ARDS can be determined by measuring the ratio of PaO2 to FiO2. So as it's getting more severe, PaO2 is going to be dropping and it's going to be getting less than 150 or 300. So that's why we are going to be looking at the stages shortly and we'll see what I'm talking about. So don't forget the ratio has to be less than 300. If it's more than 300, it is not likely to be ARDS. So what are the common trigger? The number one trigger that you must always remember in your exam is sepsis. That's the number one, sepsis. Sepsis. It could be from pancreatitis. It could just be from even pancreatitis sometimes. You know, pancreatitis, sepsis, pneumonia, aspiration, blood transfusion, fluid overload, like Charlie, toxin being ingested, drowning. Drowning is a very common one. Drowning, taking a lot of fluid into the lungs from drowning. There's going to be inflammatory cytokine that will be released that will damage the endothelium and will now further cause the pulmonary edema. And also trauma. Trauma is a common cause of ERDA. So trauma, drowning, sepsis, aspiration, don't forget them. Mortality is 30 to 40%. So how would they present? Accurate onset. They have tachypnea, dyspnea, all these ones are not specific. Everybody can have it. They are going to be having high pitch rales, which is like crackles, due to what? The fluid in the lungs. So you expect crackles. Don't forget that. So these are the phases. They can initially have respiratory alkalosis because of the tachypnea. They are hyperventilating. They cannot breathe. So respiratory alkalosis. Then second phase, they start hyperventilating, which is going to cause hypocapnia, of course. And of course, the A gradient is going to be wide. A gradient is not going to be normal because this is not what? Hyperventilation, and this is not what? Breathing at high altitude. So we don't even need to cram it. Let's just assume whenever the cause is not hyperventilation or breathing at high altitude, A gradient is going to be wide. If a person is breathing at high altitude or the person is hyperventilating, A gradient is going to be normal. There's nothing like low A gradient. Don't let us go and be picking low A gradient in our exam. Very important stuff. So let's just assume anything outside those two, A gradient is going to be increased. So phase 3, acute respiratory failure, dyspnea, scatter rails, blah, blah, opacity in the X-ray. We don't need to cram the faces. Nobody is going to be asking us the faces. So what are we going to see on the X-ray? We see the bilateral opacity. You can see this bilateral opacity have a very high index of suspicion for ARDS. Once you are seeing bilateral opacity in somebody, think about ARDS, number one. So to get to the point that there's going to be severe hypoxemia, you give oxygen, it's not going to respond. So you can say that there's already intrapulmonary shunting happening. So the person will be hyperventilating, and later the person will get tired, cannot hyperventilate again. So the person is going to be having respiratory acidosis. And definitely because of the hypoxemia, there's going to be compromise of the mitochondrial pathway. So the person will have to depend on anaerobic pathway and produce lactic acidosis, which is going to cause metabolic acidosis. All these things, nobody's really going to ask us. So I'm just explaining so that we'll know the reason why all these things come about. So how do we make the diagnosis? The first thing is a acute nature. So all these features, they are going to happen within 1 week of the respiratory insult. So within 1 week, they're having all these things. Now, the chest X-ray, we are going to be seeing bilateral alveolar opacity, which is consistent with pulmonary edema. Don't forget bilateral alveolar opacity. So we expect all these bilateral opacity to actually develop after 24 hours minimum. If you see bilateral alveolar opacity within 24 hours after trauma, think about pulmonary contusion. Don't ever miss it. Think about pulmonary contusion. Although most of the time, pulmonary contusion will be unilateral. But the point still remains that people with ARDS, you will not see the X-ray changes before 24 hours. You will not. Because don't forget, it is a what? Inflammatory response. that is driving all those endothelial damage that's not allowing fluid to seep out. So at least you need a minimum of 24 hours for all those things to happen before you can start seeing the bilateral alveolar opacities. You also measure the PA FiO2 ratio. It has to be less than or equal to what? 300. Very important. And you now find out that the respiratory failure is not explained by heart failure. You can see it because you've said it already. I've explained. It can look like heart failure. But by the time you do your evaluation, you see that no, this is not heart failure. So you have to marry all these four things to now say that yes, this person is having ARDS. They're having the features within 1 week of the respiratory insult. We are doing our imaging and we are seeing bilateral opacity after 24 hours of the insult. We measure our PA FiO2 ratio, it is less than 300, and we have excluded that failure. ARDS. So what do you want to do? Go and treat the underlying problem. Is this person having sepsis? Treat it. Pancreatitis? Treat it. Drowning? Try and stabilize. Aspiration pneumonia? Treat it. You know, anything that is the cause, treat the underlying cause. There's always an underlying cause. Try to also maintain perfusion because you don't want to cause like end organ damage. Then there's something we call prone positioning. Now, you do prone positioning for people that have a moderate to severe ARDS. And how do you know that it's moderate to severe? If you calculate the PaO2 FiO2 ratio, it is going to be less than 150. So anybody having a ratio less than 150, you want to consider prone positioning. And what are you doing in prone position? Let's just picture that this is somebody. This is me now. And this is me facing down. This is my eyes here. So I'm facing down. So now, if somebody faces down like this, there's going to be less compression on the dorsal alveoli. That is what they are trying to do. So they are trying to reduce compression on the dorsal alveoli so that they can recruit them to participate in oxygenation. That is the idea behind doing prone positioning. So that you can reduce compression on the dorsal alveoli and recruit them for oxygenation. That is it. So once they lie down like this, there's less volume of fluid compressing on them. So, gravity is going to act downwards and, it's going to be compressing on only the structure that are anterior. So all these ones here, they are free. So oxygenation can happen in that place and, the person can have a better outcome. Prone positioning, don't forget it. You also want to place them on mechanical ventilation, but you want to be careful. You want to use low tidal volume. Don't forget there's fluid washout, the lung has already collapsed. So in a way, if the lung has collapsed, I want to just test our knowledge here. If somebody is having ARDS and the lungs have collapsed due to the surface tension acting, inwards, what kind of lung disease pattern can we attribute that to? Is it going to be obstructive or restrictive? Anybody? Is it obstructive or restrictive if the lung have collapsed?
Restrictive.
Restrictive. And we said it yesterday. I don't know if I mentioned it yesterday. I'm not sure. Like people with restrictive lung disease, you see them having like a rapid, shallow breathing. So they take a rapid, shallow breathing. So what they do is that they're trying to increase the respiratory rate and they reduce their tidal volume. So because of the reduction of the tidal volume, because there's no space already, it's shrinking. So reduce tidal volume. But to increase ventilation, increase your respiratory rate, but reduce your tidal volume because there's no space to take in your tidal volume. So if I want to maintain ventilation in them, I have to do something that can help me increase my respiratory rate. That's why people with interstitial lung disease, most of those restrictive lung disease, you see them, they have a rapid, shallow breathing. That is the idea. So the same thing is what you are going to try to employ in people with ARDS. There's no volume again. The lung has collapsed. So if I want to increase ventilation with a mechanical ventilator, what I'm going to do is that I'm going to do an adjustment that will allow me to, provide a lower tidal volume, but increase my respiratory rate. So that is a step 2 question for you. It will be as confusing as anything for some people, but now we have made it very clear. Any setting you are going to be doing your mechanical ventilator, make sure that it is going to drop your tidal volume and increase your respiratory rate. That is it. Because you don't want to allow for over distension of the alveoli. The alveoli is already kind of collapsed. If you now go and over distend it, it can burst. So just do anything that will allow for lower tidal volume, but increase your respiratory rate. You are going to do the reverse if the person have obstructive lung disease. So for obstructive lung disease, go and increase tidal volume, reduce your respiratory rate. So to cut the stuff very short, just know that obstructive lung disease, restrictive R. So restrictive, there's R there, increase respiratory rate. R, restrictive, respiratory rate, R, increase respiratory rate, decrease tidal volume. Then you do the reverse for obstructive, because in the exam, we might not have enough time to be doing critical thinking like that. So that mnemonic, restrictive lung disease, increase respiratory rate. Obstructive, reduce respiratory rate and increase tidal volume. It's as simple as that. So we are going to be taking ARDS as a form of restrictive. So you use low tidal volume, less than 6 millimeter per kg. So the ideal one is between 6 to 8. That's the ideal. When you place them on mechanical, you can just use 6. Put it at 6. It's okay. It's okay. Then don't forget, you want to also increase this. So this is to increase ventilation. If you want to, increase oxygenation in them, you are going to adjust the PEEP too, so that you can recruit some collapsed alveoli. But you have to titrate your PEEP and your FiO2, which I'm going to talk about shortly. So to increase oxygenation, increase the PEEP in them. Also increase FiO2, but don't make it more than 60%. Very simple. Very simple. They give us a situation. Someone have ARDS, blah, 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 blah. How do you want to increase oxygenation? That is not the time to go and be picking adjust tidal volume. It shows that the person doesn't know what he or she is speaking, or go and be picking adjust respiratory rate. No. So just look for something that talks about our PEEP or FiO2. So either you increase FiO2 or increase PEEP. You now look at the question. Is FiO2 already adjusted to maximum? Yes. Stop. Don't touch FiO2 again. Just go and touch the PEEP. You can increase it to 5 millimeter mercury or more than 5 millimeter mercury. Your goal of oxygenation is to keep your PO2 more than 55. So ideally, first aid puts hypoxemia to be less than 60, fine. But for somebody to be said to have hypoxemia leading to acute respiratory failure, the value has to be less than what? We talked about it yesterday or the day before yesterday. It has to be less than what?
50.
50. It has to be less than 50. So make sure you keep it above 55 and SpO2 keep it above 88. So, so there's something you call permissive hypercapnia. They can ask in the exam. Thank God I have it here so that I don't forget. So now, if we look at what we are talking about, so we said you want to reduce tidal volume in people with ARDS. Please don't forget, if we reduce tidal volume, what do you think is going to happen to ventilation in a way? Is it going to drop or is it going to be increased?
Drop.
Ventilation will drop. Ventilation will drop. What will happen to PaCO2 value? My people, no catch. What will happen to this? It will increase. So that is what hypercapnia, right? So it is allowed for that to happen in somebody with ARDS because we prefer the person to have hypercapnia than to have over distension of the alveoli from increased tidal volume. So that's what we call permissive hypercapnia. We prefer to go and deliver a low tidal volume so that we don't burst the remaining alveoli that are already all the alveoli has already collapsed. Now the remaining that is now there, let us quickly maintain small tidal volume so that we don't collapse them. But we know that if we go and maintain low tidal volume, what's going to be the consequence of that? Our PaCO2 is going to increase. So we are okay with that to happen. That is it. The concept behind permissive hypercapnia. They'll put in the exam. Some people will be confused. What are they saying? That's the option you are going to pick. Allow for permissive hypercapnia by using a low tidal volume. You pick your answer, you move, you are smiling in the exam. People are coming out, that exam is tough. You know what you are picking and you can defend, the reason behind that choice. So don't forget the concept of permissive hypercapnia. Say it to yourself every time. Don't ever forget it. So when do you extubate people with ARDS that you have placed on mechanical ventilator? How do you extubate? So you can extubate if the cause of the respiratory failure has improved. So the person having sepsis, you have given antibiotics, the parameters are now, looking fine. You can extubate. If you are delivering a low ventilatory support, so I'm going to talk about the support later. We should not worry about it. It's just the next thing to discuss. So if you are now you are providing mechanical ventilation, but at a low pressure support, you know that, okay, this person is getting well. I'm decreasing my PEEP, I'm decreasing, my platelet pressure, and everything is still going fine. Oh, it means that this person is doing well. We can extubate. Third point is very similar to second point. The last one is if the person passes a spontaneous breathing trial. So what you do is that you can place a T tube. There's something we call a T tube. You put it to the endotracheal tube in the person, and we watch, the respiratory parameter if it improves. So if the person is if we apply the T tube to the endotracheal tube and the person is not having like tachypnea, respiratory rate of 35 cycles per minute, you know that the person has not passed spontaneous breathing trial. The person cannot breathe on his own. So at that point, you return your intubation. But if the person is still able to stabilize while using the T-tube only, not connecting the endotracheal tube to the mechanical ventilator, then you can say that this person has passed, spontaneous breathing trial, and you can extubate. Now, let us try and look at mechanical ventilation. It looks complex, but we'll try to break it down. Somebody wants to ask a question. Yes.
Yes, Dr. Baba, but please, can you explain the benefit of prone positioning again?
So prone positioning, look at this. This is somebody's back like this. This is the face here. This is the face. So somebody is being positioned like this. Gravity is acting this way. So gravity with the, this person having pulmonary edema. All the lungs here, they are filled with like fluid. So gravity is going to be compressing more, because if the person is lying vertically, I just want you to picture it yourself. If the person is having vertically, gravity is going to be acting uniformly on all the alveoli. It's going to be uniform. But if you place the person on prone, so what is going to happen is that all the alveoli that are posterior, that are at the back, they are going to be free from the effect of gravity. So the ones that are only going to be compressed are the ones in front, in the anterior aspect. Because you know that the fluid is going to gravitate like this. Can you picture the fluid gravitating like this? Do you understand what I'm saying? So they are going to compress on the anterior alveoli. So it means that the dorsal alveoli will be free of the pulmonary edema, so that they will be available for oxygenation. Can you picture that?
Yes. Thank you.
That is prone position. So moving on to mechanical ventilation, this will look a little bit complex, but I will try my best. Please, I just want us to follow me. So this is a process in which we try to move air in and out of the lungs using external device. So it could be invasive or can be non-invasive. So many people just think that mechanical ventilation is invasive, but no. Even if we give CPAP, in a way, it is like, mechanical ventilation, but we are not intubating. So that's the difference between intubation and CPAP. Both of them, they are mechanical ventilation process. If you intubate, you connect that intubated patient to a mechanical ventilator. If you did not intubate somebody and you apply a CPAP machine, that is still a form of mechanical ventilation. So that is what I want to say. So using intubation connected to a mechanical ventilator machine, that is invasive mechanical ventilation. But if you just apply max connected to a CPAP machine, that is a non-invasive mechanical ventilation. So what are the indications? Inadequate oxygenation, inadequate ventilation. Those are the two things that should come to our mind. If step 2 was husky now, and we are asked to say it, that's what we are going to say first. Inadequate oxygenation, inadequate ventilation. So we can change it, that inadequate ventilation is something that's going to be allowing PaCO2 to accumulate. Inadequate oxygenation is something that will allow PO2 to reduce. So inadequate oxygenation, you're having acute hypoxemia of anything. It could be from atelectasis, airway issue, or inadequate ventilation. Why are you not ventilating? Why is your PA2 increased? Are you breathing at high altitude, or are you like having Guillain-Barré? That is why people with mastanic crisis in neurology, Dr. Babangida would have said it, intubate, and what? Monitor them by doing what? Anybody remembers what we do? Monitoring people with mastanic crisis and Guillain-Barré. What do we do?
Everything.
Yeah,
You monitor
exactly.
the everything.
The what? Yeah, exactly. You that is step 2 exam. That's the way they will be asking question. You monitor their vital capacity and their menu ventilation. You are monitoring it. Intubate because of what? Inadequate ventilation. So somebody with flare chest too, you want to intubate because of what? Inadequate ventilation. They cannot ventilate. Anybody that has problem with maintaining their airway because they have alter sensorium, we go to the ICU or we go to the emergency. We calculate the GCS. It is less than 8. One, we'll send consult to ICU because of what? Mechanical ventilation. And all these ones, they are invasive. You have to go and intubate them. You can't be using CPAP in someone that cannot maintain airway. It is not possible. It is not possible. Someone that cannot achieve inadequate ventilation, you cannot use CPAP. No, because CPAP is more like it augments ventilation. It doesn't provide the ventilation. It just helps you with the breathing. It cannot trigger the breathing, but a mechanical ventilation process that is invasive, that one can take over the breathing. It will be the one triggering the ventilation for the person. So all these indications we are talking about is for invasive mechanical ventilation where you have to intubate. And of course, if somebody have hemodynamic instability, blood pressure low, everything low, go and intubate. So, so we should not forget flare chest. Flare chest is just when you have, breakage of 3 or more ribs, in an adjacent pattern. So, you just notice that everything is just going to move in the paradoxical direction. Ideally, when there's the break like that, you will see that the broken ribs, they will be moving inwards during inspiration. So you can just use the letter to remember it. Inspiration, inwards, high, high. So when the ribs are broken, they move inwards during inspiration and they move outwards during expiration. That's not the norm. So once you see that being described in the question stem, you know that is flare chest. What do you want to do? Just go and mechanically ventilate or deliver a positive pressure so that you can force out. So that broken rib segment that is moving in during inspiration, once you apply a positive pressure, it will force it out during inspiration so that you can allow space for the lungs to expand to bring in air. It's as simple as that. Positive pressure ventilation is the solution to improve oxygenation in what? Flare chest. So let's look at the respiratory mechanics in mechanical ventilation. So they will just give you this diagram like this to confuse us, and they will start asking us a manner of questions. Let me see. I don't know if we have any question before I go too far. Okay. Not sure. I think I do. Okay, let's look at this. A 53-year-old homeless man comes to the emergency department due to several days of shortness of breath and productive cough. A month ago, the patient was evaluated for dysphagia and was found to have candida albophagitis. He received nystatin but refused any further workup and left against medical advice. The patient uses cocaine and intravenous heroin. Temperature is 38.8, blood pressure is 121, pulse is 124, regular respirations are 22 cycles. Oxygen saturation is 89 on 2 liters per minute of oxygen by nasal cannula. He is awake, alert, and in mild respiratory distress. There are extensive white plaques over the oral mucosa. A 2/6 mid-systolic murmur is heard at the left upper sternal border. Lung auscultation is remarkable for a faint bilateral crackles. There are no jugular venous distension or lower extremity edema. Which of the following is the most likely underlying mechanism response for this patient? Hypoxemia. Anybody? What's our answer?
Is it ventilation perfusion mismatch?
Yeah, ventilation perfusion. Means that this guy is likely having like a pneumonia from the candidal, infection. So can you see the crackles and the likes? So this is
Yeah.
going to be like ventilation perfusion mismatch. Don't forget about that. All these other ones cannot cause it. Alveolar hypoventilation, no. It won't explain the crackles. It won't explain, it doesn't relate to candida. This person having cough, sharing of breath, can't be thinking of hypoventilation. So the respiration are even 22. It's not hypoventilating. So increased pulmonary capillary wedge pressure. What is this one saying? What's the diagnosis for this? From what we have said, heart failure. This is not heart failure.
Heart failure.
This is not heart failure. Left to right, this is not a VSD. Pulmonary hypertension. It doesn't even make sense. So that is VQ mismatch from in pneumonia. So let's see this. Yeah. So I'm so sorry. Let me try and bring this up. A 28. Oh no, let me leave this. We've not got into this. Let me leave that. Should not be there. Let's see this. A 35-year-old woman is evaluated at the bedside due to new onset, rapidly worsening shortness of breath and hypoxemia. A day ago, the patient was admitted to the hospital for sepsis due to ascending cholangitis from gallstone obstruction of the common bile duct. Endoscopic retrograde stone removal was performed shortly after admission, and she's receiving IV fluids and broad-spectrum antibiotics. Temperature is 38.9, blood pressure is 102, pulse is 118, and respiration 35. Oxygen saturation is 84 on a non-rebreather max with FiO2 at 90%. The patient appears anxious with labored respirations. Cardiovascular examination shows normal heart sounds, normal jugular venous pressure, warm extremities. Pulmonary examination shows a faint wet crackles diffusely. The patient is intubated and she's transferred to the ICU. Chest X-ray is shown below. ECG shows tachycardia, cardiac troponin I is normal. Bedside transthoracic echo shows hyperdynamic left ventricular contraction with trace mitral regurgitation. Blood cultures are negative and gram stain shows no organism. Which of the following diagnostic test is indicated at this time? What's our diagnosis going to be here? Anybody?
Acute respiratory distress syndrome.
ARDS. So which of these tests are we going to do? Anybody? Which of these are we going to pick?
No testing.
No testing. Be confident in picking no testing. I can assure you there will be some situation in your exam that we have to pick do nothing. Once you know your stuff, you can confidently pick do nothing. So in this situation, no additional testing. This guy doesn't have bronchiectasis or interstitial lung disease or sarcoidosis. There's no need for high resolution CT. What are we looking for? Why do you want to do lung biopsy for ARDS? What are you looking for? Pulmonary arterial catheterization. This is not pulmonary hypertension. You don't need that. Transesophageal echo. Why? They just want to confuse us. Everything here is reeking of ARDS. There's fever. There's tachypnea. He had sepsis. Now he's developing wet crackles. Some people might think it's heart failure, but they told us heart sounds are normal. No S3. Normal jugular venous pressure. Extremities are warm. So that is ARDS until otherwise proven. I'm not sure I have that X-ray, but okay, I have the X-ray. Here. So we look at the X-ray. We can see the opacity here. We can see under opacity here. That's ARDS. So yeah, that's a good one. Do nothing. So don't be afraid to pick do nothing. No. Just make sure that you have ruled out everything and you are sure before you pick it. So let's look at this. A 44-year-old man is admitted to the hospital due to severe abdominal pain and vomiting. The patient reports drinking about 10 shots of whiskey daily for 6 months. He has no other medical condition. The patient is diagnosed to have acute pancreatitis and receives intravenous fluid, pain control, and MPO. On the second day, he reports a sensation that he could not get enough air. The patient is afebrile. Physical examination shows bilateral crackles. Chest X-ray shows bilateral diffuse alveolar opacity. Echo shows normal left and right ventricular function without major valvular disease. He undergoes endotracheal intubation and mechanical ventilation due to progressive hypoxemia. Which of the following treatment strategies is most likely to decrease the patient's risk of in-hospital mortality? This one is tough, but we can get it. We have talked about it. A. Avoiding alveolar hypoventilation. B. Avoiding respiratory muscle paralysis. C. Decreasing alveolar recruitment. D. Increasing ventilation in the ventral lung regions. E. Preventing alveolar overdistension.
Preventing overdistension.
Tension.
The what? Preventing
Preventing
alveolar
overdistension.
overdistension. And how do we prevent that?
Prone positioning.
No.
By reducing pitch.
By reducing the
By reducing the tidal
By
volume.
reducing the tidal
yeah and
volume.
the
By reducing the tidal volume. So option D is against prone positioning, increasing ventilation in the ventral. Are we increasing ventilation in the ventral? No. We are increasing in the dorsal. Decreasing alveolar recruitment. No. We even want to recruit more alveoli. And that is why we are doing the dorsal positioning. Avoiding respiratory muscle paralysis. Why? And avoiding alveolar. So all those one doesn't make any sense. Let's look at this one. Let me see people that can pick things. So a 16-year-old boy is brought to the emergency department after a drowning incident at the swimming pool. He dove into the water, hit his head against the bottom of the pool, and lost consciousness. He was pulled out of the water shortly after the incident and took approximately 2 minutes to regain consciousness. On arrival, he's conscious and responsive. Temperature is 36.8. Pulse is 88. Respiration at 15. Blood pressure is 124. Pulse oximetry on room hand shows oxygen saturation at 94%. This is scan of the head and X-ray of the chest show no abnormality. 6 hours after, he's short of breath and confused. Pulse oximetry on 1%, 100% oxygen. 100% oxygen at 15 liter via non-rebreather mask show oxygen saturation at 85. Chest X-ray shows diffuse bilateral infiltrate with hair broken. What do we think about this oxygen saturation at 100%? What do we think?
It's low.
Is what?
It's low.
It's low. So do we think that this guy can we say that this guy is having like shunting already? Okay. So we're just
yes
quiet.
Yes.
This guy's not
Yes.
really, improving.
It's not important.
Yeah.
Mhm, because of the 100% oxygen.
100%, and you are saying at 85. What's going on? So chest X-ray shows diffuse bilateral infiltrate with hair brachiograms. Is intubated and mechanically ventilated with FiO2 of 0.9, a PEEP of 8, a tidal volume of 408, which is at 6 ml per kg, and respiratory rate at 20. The next day, arterial blood gas is as shown. pH is 7.3, PCO2 is 47, PO2 is 140, oxygen saturation is 100. With the following mechanical ventilation settings, the patient is at greater risk of which of the following? Anybody?
Oxygen toxicity.
Oxygen
Oxygen
toxicity.
toxicity. Why?
The FiO2 is more than 60%.
Thank
They've
you.
increased it.
Thank you.
Mm.
FiO2 is now more than 60%, and this guy is now having PO2 of 140. So this guy is at risk of oxygen toxicity from free radicals. That's very good. Good attempt. Good attempt. Okay. So mechanical ventilation. We are talking about the indications. Don't forget inadequate oxygenation, inadequate ventilation. Those two, they go together. Oxygen, CO2, oxygen, CO2. Then airway compromise. Don't always forget that. Airway compromise. Maybe the person is confused, intoxicated, having seizures. Just go and intubate. or hemodynamic instability. So status epilepticus, intubate. So let's go to the mechanics. So let me start by just talking. Let's just take them one by one. So let me quickly draw something here, and we'll just assume that this is the airway here, and this is the alveoli here. Let me just say this is like the lungs in total, and we have like alveoli somewhere here. Now, to get air into this lung, there are some pressure that we need to surmount. That's the way to look at it. There are some pressure that we need to override before we can get air into this lung. And the first one is the resistance, airway resistance in this lung, in this airway. There are some resistance that will not, we have airway resistance, like what we did in our physics. If you drop something, the weight is acting against airway resistance in the air. Because of air, it has airway resistance because there's air here. So there's going to be airway resistance that you need to overcome before you can push in here down. And also because of the fact that it is a closed loop, don't forget, from this airway now is going to, okay, everything is going to come out to the mouth. Then from the mouth, we are going to connect the pipe to the what? To the, it's not even from the mouth, it's at the neck. That's where we intubate, at the neck. So we are going to connect that to the pipe and the machine. So now the resistance is even all the way down from the piping to the neck, then down to the airway. So this machine needs to overcome this airway resistance. So that pressure that we deliver to overcome that airway resistance from the tubing to this person's throat, airway, is called resistive pressure. Resistive pressure. That's the first pressure. Now the second pressure is now when that needs to be overcome before you can get air into this lung, is the compliance pressure. Let me explain that. You know that if we get air into this, what's it called? Into this system, this lung like this, the lung is an elastic tissue, don't forget. It will want to recoil on itself. So that means that we need a pressure to expand it. No, you are not going to recoil. No, I'm going to get air into this place and you are going to stretch for me. You are going to move outwards. That is what we call the compliance pressure in a way. But it has another name. They call it elastic pressure because that is a pressure you are delivering to overcome elastic recoil. So that is elastic pressure. What do we think will happen to elastic pressure in a lung that is not compliant? I just want to try and create some confusion. Let me see if you can figure it out. A lung that is not compliant, what will happen to elastic pressure? Anybody? It's going to increase.
High.
It's going to be
Pretty
increased.
high.
You have figured out everything in this system. We are done. I think we are done with this explanation. It is high. You see now that we are done. It might look like a play or like I'm joking, but that is once you have figured that out. we are done with everything we are seeing in this diagram. Now the last one is a PEEP. So you need to deliver. After you have delivered pressure that would help you, overcome the airway resistance, and you have delivered pressure that will help you overcome the elastic pressure, then you need to deliver a pressure that will help you keep the alveoli open at the end of expiration. And that's what we call the PEEP. The PEEP. So before I answer that person's question, I'm coming, doctor. I'm coming. The total pressure that you now administer is a sum of the restrictive pressure, elastic pressure, and the PEEP. And that's what you call the peak inspiratory pressure. That is the total pressure required to push in air into the lung. Now, doctor, I'm with you. What's your question?
Yeah. Elastic pressure, as it is used here, is it the same as elastic recoil pressure?
Yes, you can call it elastic recoil pressure. Just call it
Okay.
pressure you use to overcome elastic recoil pressure.
Okay.
That is it. So the sum of the three, restrictive pressure, elastic pressure, and the PEEP, is called the peak inspiratory pressure. So that is the total pressure required to push air into the lung. So if the question puts in the question that what is the total pressure that used to push in air into the lung, you pick the peak inspiratory pressure, PIP, which is the sum of what? Restrictive, elastic, and your PEEP. As simple as that. Now, let's now look at some other things that they have broken down. Now, they now broke it down again. They now said peak inspiratory pressure is the sum of the plateau pressure. Don't get confused though. Just follow me. Plateau pressure plus restrictive pressure. So we can say that plateau pressure is the sum of elastic pressure and PEEP. That is it. Plateau pressure is the sum of elastic pressure and PEEP. That is plateau pressure. So plateau pressure plus resistive pressure, they are the peak inspiratory pressure. So plateau pressure reflects lung compliance. Don't forget, we have said it, because plateau pressure like contains elastic pressure. So definitely is going to be affected by compliance. So if there's reduced compliance, there's going to be increased elastic pressure, just like we said the other time. And it means that the plateau pressure is going to be increased. Don't worry, I'm going to show us in the diagram. Then the residual pressure, we have said this already, which is a pressure that comprises of the pressure within the ventilative circuit. Don't forget the tubing, the endotracheal tube itself, and the patient airway. We have explained that. That's the resistive pressure. We have talked about the PEEP too. That's the pressure that remains, that remains in the alveoli at the end of expiration to keep the alveoli open. That is the PEEP, and the PEEP is also part of the plateau pressure. So PEEP plus elastic pressure equals the plateau pressure. Is there anything I'm missing here? Yeah. So we have talked about elastic pressure. Elastic pressure is the one due to elastic recoil of the lungs and chest wall. The one that you need to overcome is what? The elastic pressure. So elastic pressure is going to be increased if there's lung stiffness. That lung is stiff. It's like it's coming close together. You cannot expand it. Elastic pressure is going to be high in there. Or if there's reduced chest wall or diaphragmatic movement too, like people having ascites, obesity, just think of anything that can cause like restrictive lung disease in a way. There's going to be a need for increased elastic pressure in that kind of person, because the lung is kind of shrunken, compressed together. So you need to break that elasticity and expand it. So anytime you need to deliver more force to expand the lung, elastic pressure is going to be increased. You need to deliver more pressure to overcome that elastic pressure. So in situation of fibrosis, obesity, ascites, you need to deliver more elastic pressure. Now let us now look at the diagram. Let's look at the diagram. So now from here to here, this is our total pressure. So that is the peak. So just trace it. That's the peak inspiratory pressure. Peak inspiratory pressure. Now, to measure plateau pressure, there's something we do. We call it the inspiratory hold. I will explain. So if you look at this curve, so there's like plateau pressure, there's like expiration, there's a break, then the person takes in here again. It peaks again. Now at this point, the machine is going to deliver what we call inspiratory hold. The person will not breathe. It will hold it at that point. So at that point, we no longer have a resistive pressure again, because there's inspiratory hold. So you are not delivering, at that point, we can say that we are not actively moving air against that airway again. So the only force that is remaining in the lung is just the force to expand that lung, because I'm not moving anything actively again. So I'm not overcoming any resistive pressure. But the one I have moved in, I need to get it to expand that lung. So the pressure that will be exerting its force in that lung at that point is going to be the plateau pressure. So that is why when you want to measure the plateau pressure, you try to eliminate resistive pressure. And the way you can eliminate resistive pressure is by doing inspiratory hold maneuver. So at this point here, they will do inspiratory hold. So from this point to this point, this is the resistive pressure. Then the pressure from now this point to this point is now the plateau pressure. So once you see a plateau like that, you know that it is at that point that the plate-to pressure is reading. So from here to here is now going to be the plate-to pressure. And don't forget, plate-to pressure is the sum of what? PEEP and elastic pressure. So PEEP plus elastic pressure plus resistive pressure all totally equal to the what? To the PIP. So if they give us in the exam and they are labeling the part, that what is the pressure between this part and this part? PIP. What is the pressure between this part and this part? Resistive pressure. What is the pressure between this part and this part? That is your elastic pressure. That is your elastic pressure. So the one beneath here, from here to here, is our PEEP. PEEP is always at the baseline. So if you had PEEP to elastic pressure, it will, total the plate-to pressure. So, but from here to here is actually your elastic pressure. So, yeah, so that's just like we can see in the diagram, elastic pressure. But this, point is our, plate-to pressure, because we are assuming that it's starting from like baseline PEEP, which is like 5. So this portion is just the baseline PEEP, because PEEP can never be 0. If PEEP is 0, that lung has collapsed because there's nothing to keep it open. So the minimum PEEP is usually 5. So it is usually at this level. So this is 5, for PEEP. And this is the difference between them is the elastic pressure, then we have the resistive pressure. So the sum of this, and our PEEP is going to be our PIP. So now, let me now, I don't know if I can clean this thing, but it will be hard for me to clean. Let me just draw another diagram here to just show us something. Okay, no, I don't need to draw down that diagram. Let me just show us through the clinical scenario they will now give us. Now, I want to let us look at this diagram very, very well. Now, I want us to follow the blue line for now, only, blue line, only. So, this is a baseline PEEP. We deliver inspiration, takes in here. So, here like this, it rises. So, it means that this is what? This is the PEEP, baseline PEEP. This is PEEP, right? I have to be cleaning all these things, but we'll get that. PEEP. Okay. Now, at this point, they deliver inspiratory hold. So the pressure from here to here is what? What is this pressure? From here to here?
Resistive
Resistive pressure, exactly. So this is a
resistive
plate to. This is a plate to here. So this is going to be the plate to pressure. So the difference between this part and this part is going to be the what? The what? Here to here.
Elastic pressure.
Elastic pressure. Thank you very much. Elastic, pressure. So this is elastic pressure. Now, if you go to this image, this is now the changes that have happened. This is the change that has happened. Do we think that the plate to pressure have changed in this person? Look at the old.
No.
Exactly.
No.
So the only change that happened is that the what? Resistive pressure. And what happened to the resistive pressure? It what? Increased.
Increased.
So because the resistive pressure increased, PIP will also increase. Don't forget, PIP is the sum of resistive, elastic, and PEEP. So if any one of them increase, PIP will always increase. So that's why we are always seeing PIP. We are seeing PIP increasing, and we are seeing the resistive pressure increasing. So this kind of person, we just look for a cause of increased resistance in the airway, and we are going to get to that. If we look at this one, just look at the part for play 2. We are seeing that the ones that play 2 increased. We know that definitely this one is the issue with elastic or play 2 pressure. There must be a problem with compliance. Why is this lung not compliant? We have to look for the cause. And we can see that is also transferring to an increase in the PEEP too. You can see that PEEP is increasing in this person too, But what do I want to say? If you measure the resistive pressure, it did not change. Some people think that it changed. It did not change, because the resistive pressure is always the distance between your PIP and your plate 2. So if you look at this part to this part, it will be the same as this part to this part. Do we agree with me?
Yes, sir.
So once you see that plate 2 part has increased, you know that this is the cause of this change is going to be like a plate 2 problem, like compliance problem. Once you see that the plate 2 is normal, but there's still an increase, you know that is restrictive problem. Now let's take the causes one by one. So what are the causes of increased resistive airway pressure? Anything that increases airway resistance, but with normal lung compliance. So is it that there's kinking of the endotracheal tube? Is it that there's mucus in the airway that is creating like obstruction there? Or the person's having bronchospasm? So if it's due to kinking on tangle, if it's due to mucus plug suction, that's why you see them suctioning endotracheal tube. Probably because the peak expiratory pressure is increasing, and the resistive pressure is also increasing. Then if the person is having bronchospasm, bronchodilate. If the person is having a narrow endotracheal tube, change it to a wide one. All these things can cause, increased respiratory airway pressure. What about for decreased compliance? If compliance is decreased, it cannot stretch. So that means that there's going to be like increased elastic recoil. It is moving inward because it cannot stretch. So when it's moving inward too much too, that's an increased elastic recoil. So you need more force to overcome that elastic recoil. So that means that elastic pressure is going to be high. So what are the causes of decreased compliance? Why can it not stretch? Why? Are you doing a main stem endotracheal intubation? Why? So now let us look at what that means. So if you look at the lung, this is the trachea, bifurcating into the main stem bronchi, the right and left. So ideally, we're supposed to put the tube like 2 to 3 centimeter superior to the carina. This is the carina. This is the point of bifurcation. That's the carina. The tube is supposed to be here, so that I can have hair moving like this, moving like this. But if you go and do a main stem intubation, so that means that the anesthetic did something like this. This is a left bronchial space, and this is the right bronchial space. So if the person now go and intubate like this, this is going to be a main stem intubation. So this is a right main stem intubation. Now, what is going to happen is that all the hair is going to be delivered to this right lung. There's nothing that is going to be delivered here. And what will happen to this lung? Anybody knows what will happen to this lung? If there's nothing delivered, it will collapse. What do you think will happen to the compliance? How will you say what is the compliance of a collapsed lung? Is it increased or decreased? A collapsed lung? Decreased. So you want to go and retract. So your simple answer would be like a situation that somebody had trauma, they intubated. They now notice that there's decreased breath sound at one area. They now also notice that PIP is increased, and also platelet pressure is increased, decreased breath sound. You now did X-ray. You are seeing homogeneous opacity. It's like that lung is as collapsed. Though. Please go and retract your tube. Atelectasis too. Similar presentation. So you want to do, most of the time it could be like maybe from mucus plug. It could be, so just do like bronchoscopy to see whatever is there, and sometimes you can do chest percussion to bring out all those mucus for atelectasis. Atelectasis and main stem stuff is kind of the same, in terms of their presentation, to be very similar. But once you do your that's why once you do intubation, it's good to do like ultrasound to see, or like X-ray to see where the the chest tube is sitting, where the intubation stuff is sitting, so that is that the carina or is beyond the carina. So pulmonary edema too, the same thing. If there is fluid in the lung can never be compliant. So the compliance too is going to be reducing, just like someone with ARDS, that there's pulmonary edema, compliance reduce. ARDS too and like pulmonary edema, they are like the same thing. So if it's pulmonary edema, just go and give diuretic, maybe from heart failure, give diuretics. It's from ARDS, we know what to do. Just give low tidal volume, maintain your PEEP, which is a ventilation strategy. Don't forget that. Permissive hypercapnia. Don't forget the complication of that. There's going to be permissive. There's going to be hypercapnia, which we are permitting. So somebody with pneumothorax too, similar presentation. There's too much hair in the lungs. The lung can never be compliant when there's too much hair. It will never respond to your expansion. It will be like, well, enough is enough. Enough is enough. I'm too, saturated. Why? Because if this is the lung and this is a pleural, and we have a lot of hair in this pleural, because that is what pneumothorax is all about. a lot of air in between the pleural space. So there's no way this guy can expand. There's no space to expand. So compliance is reduced. So go and needle this guy. If it's a tension pneumothorax, go and needle. If it's a large pneumothorax, go and put chest tube. That's another thing we have to be careful. Some people just see pneumothorax and go and be putting needle. They will miss it. So if it's tension, needle. If it's not tension, it's just large pneumothorax. There is not tension. Go and put a chest tube. Very important stuff. So the ventilation settings, we have talked about it. So how do you change your ventilation settings? So there are different settings, the pressure assist, the volume assist, but we are not doing that because we are not doing anesthesiology. We'll be learning all those things in residency. So let's just know what we need to know for our exam. So for the volume assist, so you are just changing the volume. That's what volume assist means. For pressure assist, you are changing the pressure so that the change in pressure can affect the volume. But for volume assist, you change the volume so that the change in volume can affect the pressure. That's the idea. So whatever setting you want to do. So now for the volume assist one or volume control, you want to change the tidal volume. That's what you are changing. So, and we said it, people with restrictive disease like ARDS, thank God you even have it here. Restrictive disease like ARDS. What do you want to do with the tidal volume? You bring it down. 6. If the person having obstructive, like COPD, what do you want to do with tidal volume? You put it at between 6 to 8. Logical stuff. The rate is set lower for obstructive. You have said it. Obstructive, increase tidal volume but reduce the rate. But ARDS, increase the rate but reduce the tidal volume. You can see that we don't need to cram anything here. So you can start your FiO2 at 100, but titrate it down. Don't put it at this 100. You start at 100 to get the person to the maximum, but titrate it down, bring it down till get to less than 60 to prevent oxygen toxicity. And don't forget the target is to get our PaO2 to more than 55 if possible, and SpO2 to more than 88 if possible. The high E ratio, that's the inspiratory-expiratory ratio. Definitely in people with obstructive lung disease, you want them to spend more time in expiration, because the problem in obstructive lung disease is that there is narrowing at expiration. So allow them to have more time at expiration so that they can have good time to get out all those air and prevent air trapping, because that's the cause of auto-peeping in them. There's something called auto-peeping that I failed to mention. Auto-peeping means that, don't forget, we said peep is the volume of air that remains at the end of expiration. Now, what happens to the volume of air that exists at the end of expiration in people with obstructive? Sorry, I've said too many things. What happens to the volume of air?
Increase.
It will increase. Thank God somebody will get what I'm saying. So it will increase. So we can say that in a way, peep is increasing in them. So that is what we call auto-peeping. It's not too good, So that's auto-peeping. So you need them to spend more time in expiration so that they can easily get out all those volume. Yeah. So change the settings according to the pathology. We don't need to cram anything. Just understand the pathology. Is it a restrictive pathology or obstructive pathology? We know how we are going to change it. Don't forget RR, rate for restrictive. Increase rate if it's restrictive. So we've talked about this. If PaO2 is reduced, go and change the parameter for ventilation, for oxygenation, which is PEEP or FiO2. But you want to be careful with FiO2 because of toxicity. If the problem is reduced PaCO2, you know that what we are going to change is what? Ventilation. So go and decrease respiratory rate or decrease tidal volume. If it's increased PaO2, go and increase that. But if you are to choose between increasing respiratory rate or increasing tidal volume, which one are we going to choose? Anybody? Which one are we going to choose?
Respiratory.
Increase respiratory rate. Because if you go and increase tidal volume, you can end up busting the alveoli. So preferably to adjust respiratory rate over tidal volume in situation where low tidal volume ventilation is beneficial, like in ARDS. Very, very important stuff. So what are the complications of mechanical ventilation? Ventilator-induced lung injury. Number 1, volutrauma. This is when you deliver high tidal volume. It will burst. So use low tidal volume. Keep it to 6 or just around 6 is okay. Barotrauma. This is when pressure is too much. For example, somebody is now delivering plateau pressure at more than 30 cm. Don't forget, plateau pressure is the pressure to overcome what? Anybody remember? Elastic. That's it. So you're not delivering plateau pressure so that you can stretch the thing to become more compliant. Can burst it at the end of the day. So that can mean, so that's what we call barrel trauma because of pressure. So you want to reduce that too. So it's a long protective strategy. So keep your plateau pressure also minimal because you want to prevent barrel trauma. Atelic trauma. So so this one occurs when there is incessant opening and closing of the lung. They are opening, the alveoli is opening and closing, opening and closing, opening and closing. Why? Because you don't have a stable PEEP. Your PEEP is reducing, increasing, increasing. So just increase your PEEP and keep the alveoli open at all times. That will prevent atelic trauma. So atelic trauma is when you have opening and closing of the alveoli. There's going to be release of free radicals that will damage those alveoli. So keep that in check by maintaining a stable PEEP that is increased. Biotrauma. So biotrauma can occur from all these things we have said, but the commonest cause of biotrauma is going to be atelic trauma. Because when there's cyclical opening and closing, so just picture mechanical wear and tear. Those parts are going to be wearing and tearing. So there's going to be inflammatory mediator release causing biotrauma. Oxygen effect when FiO2 is more than 60%. So keep it less than 0.6. You know. In left heart failure, PEEP is beneficial. Yeah. As it increases in temperature, and very simple stuff. Just imagine somebody's having left heart failure, and this is the right side, this is the left side. You know, we know that in the right side, blood will flow downwards through the pulmonary artery to the pulmonary capillary to the pulmonary vein, then back to the left side. That's what happens, right? Hello, are we with me?
Yes.
So now, in people with left heart failure, so it is beneficial to increase PEEP. Why? Because if you increase the PEEP, there's going to be increased pressure in the thorax, in the lungs. So that will kink the pulmonary vessels, pulmonary artery, pulmonary capillary, pulmonary vein. They'll be kinked. So that means that there's no blood to go to the left side and go and worsen that left ventricular failure. Because if there's left ventricular failure, they cannot even handle preload. So why don't you do something that will reduce their preload? So that's why PEEP is very good for them. But if you go and PEEP somebody with right heart failure, you have killed him. Why? Because you are going to increase the afterload in them. You are kinking the pulmonary capillary, kinking the pulmonary artery. In someone that has right ventricular failure, there's no way they will be able to get out blood. You know, so the blood keeps pulling in that right ventricle and they will fail at the end of the day. So have that distinction in mind. PEEP is very good if there's having left ventricular failure, but it's bad for right ventricular failure. Very important stuff. You know, so what are the complications? Other complications. So if we see somebody on mechanical ventilation and they're having acute hypotension, what do you want to think of? Tension pneumothorax. Tension pneumothorax. Suddenly, he just became hypotensive and they're on mechanical ventilation. What happened? There's something that have busted. Maybe the person have had atelotrauma, biotrauma, volutrauma, or barotrauma that has ruptured the alveoli, and air is now seeping, moving into the pleural space, causing a pneumothorax. And when it accumulates, at a point, it starts exerting pressure, on the lung, shifting the mediastinum, kinking the IVC, and leading to what? A reduced preload to the heart. So that's going to cause what? Hypotension. So you just see hypotension, tachycardia. And what are we going to see in the pressure setting? Which pressure is going to increase that would further support our diagnosis of tension pneumothorax? Anybody? Anybody? People that are following us.
Elastic recoil pressure.
Elastic recoil pressure, yes. Which is going to be evident by what?
Okay.
Peak inspiratory pressure.
Peak inspiratory pressure is the total one. So this one doesn't tell us what is specifically happening.
Pressure. The resistive pressure.
No.
Decrease compliance.
Compliance pressure.
Compliance pressure. We have said it. So what is the
Exactly.
compliance pressure? What's the one that talks about that, okay, there's reduced compliance? What pressure is going to be increased if there's reduced compliance?
Plateau
Play
pressure.
to pressure. Play to pressure. Ah, come on. Okay, please let us pay attention to all those things, though, please. Very, very important. When the only time we can think of restrictive pressure is when there's resistance. Kinking. Think about kinking, mucus occlusion, narrow ET tube. Those are the things, but any other thing is going to be plateau pressure. So here now we are going to be seeing increased plateau pressure, normal resistive pressure, but increased PIP with hypotension. Think about tension pneumothorax. So immediately you want to needle that person and you do your X-ray. So they can also have reduced venous return. So if there's increased PEEP, we have said it. If there's increased PEEP too much, they can have. If the PEEP is delivered and it's too much, there's going to be increased intrathoracic pressure that's going to kink the pulmonary vessels, the pulmonary artery, pulmonary vein, pulmonary capillary, which is going to reduce venous return to the what? To the left side. So that can also exacerbate hypotension. And that is beneficial for people with left ventricular failure. So the sedative and the opioid that we also give people that mechanical ventilation can cause hypotension. So let me see if I have any questions there. Okay, no, I don't think we've got. Okay. Oh, these are things that I have not explained. These are things I have not explained. Okay. Let's just try to explain. So I have not explained this. Okay. So a 63-year-old man with COPD comes to the emergency department due to 3 days of increasing dyspnea after running out of his maintenance and rescue inhalers. At first, he had dyspnea with exertion only, but it is now present at rest, associated with wheezing and a non-productive cough. Chest X-ray reveals lung hyperinflation with no infiltrate. This patient is admitted to the medical floor and started on appropriate therapy. He does not respond to medication. Therefore, is intubated and mechanically ventilated for worsening hypercapnia and increased work of breathing. Following intubation, a portable chest radiograph confirms appropriately positioned endotracheal tube with no infiltrate. Effusion on pneumothorax. Which of the following intervention will most likely prevent this patient from developing ventilator-associated pneumonia? Anybody wants to try? Anybody wants to try? Let's just make a guess.
B.
B, yes.
Yeah, B makes sense.
Elevate the head of the bed so that they don't aspirate. If we don't elevate, they can aspirate. So, and also we should avoid, if we place them on PPIs too, that can also cause what's it called? Ventilator associated pneumonia. PPI can be very good for stress ulcer, yes, but it can also increase the risk of ventilator associated pneumonia. And also frequent moving. So if we are moving the patient frequently, that could be causing some shifting in the endotracheal tube, which can allow, the secretion, to be finding a way around the tube and the person can easily aspirate. So don't be shifting them every time so that you don't dislodge the tube. So prevent frequent shifting, um, regular suctioning, maintain the head more than 45 degree, avoid like regular use of PPI, because if you give them PPI, that will stop production of stomach acid. So if there's no stomach acid, there's nothing to inhibit uncontrolled, growth of the microbes in the stomach. So with that, the microbes can easily proliferate and the person can aspirate and develop ventilator-associated pneumonia. So the answer is B. Okay. I'm sure there are good questions on mechanical ventilator in our U word. Let us check our U word and solve the questions there. If we understand everything I've said here, we'll be able to tackle any question on mechanical ventilator. Trust me. I don't think there's anything they want to ask that we'll not be able to figure out. Trust me. I can assure you. So moving on to COVID-19. So COVID-19 is very simple. We know it. It's from Wuhan, China, responsible for the pandemic. One thing about COVID-19 is just it triggers a very exaggerated inflammatory response. That is it. So this can be associated with a lot of thromboembolism too, because of the inflammatory processes. So they have fever, multi-organ problems, ARDS, and the likes. So let's see this question. A 25-year-old man in the ICU is intubated following acute asthma exacerbation. A repeat ABG is sent after intubation and shows a pH of 7.5, a PaCO2 of 33, and bicarbonate of 26. What adjustment should the physician make to the ventilator setting? A PaCO2 of 33, okay, and a bicarbonate of 26. What do we think is happening there?
Patient is hyperventilating.
Patient is hyperventilating. So what do we do?
Reduce respiratory rate.
We reduce respiratory or we reduce tidal volume? Let's see. We can see to reduce ventilator tidal volume, it is as simple as that. There's no catch. It's very simple. Very, very simple. So the virus can be spread. That's for COVID-19. It can be spread by respiratory droplets, and they have incubation of 2 to 16 days. Nobody's going to access that. This is not step one, And what are the presentation? Just cough, sore throat, nasal congestion, but specifically anosmia and ageusia. So the person is going to have problem with smelling and tasting. So somebody that is coughing, having sore throat, running nose, now saying that they cannot smell, they cannot taste. Think about COVID-19. So they can have different complications. Whatever complication you want to think of, they can have it. But there is a high risk of thromboembolic event. So they can throw clots because of the cytokine storm syndrome. How do we make diagnosis? Just draw a NAT or reverse PCR. NAT or reverse PCR of the nasopharyngeal samples. If you do our X-ray, it's going to show bilateral opacities. On X-ray. And they are very common at the lower lobes. So the best test is actually to do a NAT or reverse PCR. You do reverse PCR for RNA viruses, not DNA viruses, because you have to convert the RNA to DNA. That's the reverse, then you now do the sequencing. So this is the opacity at the lower lobes, COVID-19. If you do a blood count, there's going to be lymphopenia because of bone marrow suppression and because the inflammatory process, don't forget cytokine storm, they will have moved a lot of lymphocytes to the tissues. So there's little lymphocytes, in the blood. Then they can have thrombocytopenia because of bone marrow suppression, coagulation studies because of the hypercoagulable state. There's increased D-dimer, inflammatory tests like inflammatory markers like CRP, LDH, everything is increased. So what do you do? Mild, just isolate them, monitor them, provide symptomatic treatment. They are coughing, give antitussives. They are feeling pain, give analgesics. They are feeling fever, give antipyretics. They are feeling dry, give them fluid, But if it's very severe, we can give neutralizing antibodies or antiviral agent like remdesivir, So that's it. But if it's very severe, you need to hospitalize them. I've never seen a question on COVID, but it's possible, you can get it. So how do you prevent COVID? We should not forget that social distancing, wear your PPEs, masks, everything, so COVID is part of the airborne precaution. So you need to take a very serious airborne precaution, and you need to wear your PPE, your gown, and use N95 masks. So tuberculosis, COVID, measles, disseminated chickenpox, all these people, you have to wear N95 masks. They are airborne, stuff like airborne precaution needs to be taken. So you can give them vaccine to reduce severity of the illness. So don't forget, if it's very severe, hospitalized. If it's symptomatic, like moderate symptomatic, just give them, symptomatic treatment. If you want to go and visit them, use your N95 masks and wear your PPEs. So moving on to pulmonary hypertension. So we do pulmonary hypertension, we take a break, we come back and we continue. So pulmonary hypertension is just when we have the mean pulmonary arterial pressure more than 20. Very simple. We can group them group 1 to 5. Group 1 are the people with arterial hypertension. Most of the time is idiopathic due to what? Bone morphogenetic receptor 2 protein mutation. We have done it in step 1. So, and whenever there's a mutation in this BMPR2 gene, there's uncontrolled vascular smooth muscle proliferation, which leads to the pulmonary hypertension. So it could also follow some connective tissue disease like scleroderma. It could happen due to pulmonary hypertension. It could follow schistosomiasis because of the HEGs. When the HEGs travel to the pulmonary artery, there's inflammation, there's narrowing. HIV too can cause pulmonary arterial hypertension, and we can have the group 2. So group 2 is due to problem with the heart. So somebody with aortic stenosis now, or mitral stenosis, there's going to be blood pulling within the left atrium. So the blood can go back from the left atrium to the pulmonary vein, and from there to the pulmonary artery, causing pulmonary hypertension. So anything from the cardiac, MS, AS, that's going to be group 2. Group 3 is anything from the lungs. What is the lung problem that is causing hypoxia? Which is now leading to pulmonary hypertension. Because when there's hypoxia from the lungs, there's going to be pulmonary vasoconstriction. So pulmonary vasoconstriction will cause pulmonary hypertension. So any cause of chronic lung disease, asthma, COPD, asbestosis, anything can cause group 3 pulmonary hypertension. Group 4 is when there's chronic thromboembolic disease. Maybe this person having malignancy and they are throwing clots repeatedly to the lungs. That would reduce the surface area of the pulmonary vessels, leading to pulmonary hypertension because of chronic thromboembolism. Then group 5 is multifactorial. It could be from maybe sarcoidosis, it could be from DM, sickle cell, name it, group 5. So don't forget, core pulmonary can follow group 3. So they have a pulmonary hypertension from pulmonary vasoconstriction, and the left ventricle is struggling, with the afterload, struggling, and in the process there's right ventricular failure. So that is what we call core pulmonary. But if the cause of the right ventricular failure is not from a pulmonary cause, don't go and pick core pulmonary. So we won't say that anytime we say right ventricular failure, core pulmonary. No. Right ventricular failure from pulmonary cause is core pulmonary. How would they present? One thing we should not forget that they always say that these people are tired. They are dyspneic and they are tired. They do small work, they are tired. They are easily fatigued. They can have chest pain. Of course, they can have right-sided heart failure at the end of the day, which is going to present as edema, abdominal distension, and elevated GPD. So we know the cause, COPD, ILD, depending on the group, just group them. COPD is group 3, ILD is group 3, heart disease is going to group 2, sickle cell can be under like group 4 or group 5. Emphysema is going to be group 3, pulmonary embolism is going to be group 4. So when we investigate them and we try to examine, like, what are we going to see? There's going to be a loud palpable S2, particularly P2, because there's pulmonary hypertension. That sound is going to be loud. And there's going to be a split from our cardiology. What split do we expect? Anybody? What split is it going to be? Is it going to be fixed? Is it going to be wide? Is it going to be narrow? Is it going to be paradoxical? Which one is it going to be?
Paradoxical. Wide split.
Wide split. It's going to be a wide split because it's going to take a longer time for the right ventricle to empty into the pulmonary vessel, because of that pulmonary hypertension. So the right ventricle is going to be struggling for a long time. So it will take a long time for the valve to close. So there's going to be a wide split, So there's going to be a flow murmur, S4 sound. So the most important thing to just remember here is just the loud wide split S2, S4 sound. And the reason why they have S4 sound is because of the right ventricular hypertrophy. There's a right ventricular hypertrophy, concentric hypertrophy causing S4. And the right ventricular hypertrophy will also cause parasternal EV. So they're always going to be tired on exertion. Don't forget that. So what are the other causes of embolic disease that we can have? So it could be from postpartum amniotic fluid, from fracture of heart embolism. What's the triad of fat embolism? Have we done it? Fat embolism triad. So hypoxemia. Somebody wants to tell us? Okay.
Rash.
Rash, petechial rash, hypoxemia, neurologic signs, right? You'll be confused. They can have seizures. You see a petechial rash and hypoxemia. After trauma, think about fat embolism. So you want to give the person, what do you give the person?
Heparin.
No. You give the person oxygen, supportive
Oxygen.
treatment, oxygen. So cardiac surgery, they just did a cardiac surgery and the person had embolism feature. It's likely going to be hair embolism. Maybe they just needle somewhere, hair embolism. Or endovascular procedure, angioplasty. And the person was having like sudden onset feature of embolism. Just go and pick cholesterol embolism. They can put like the person having a blue toe, the person having livedo reticularis. They will tell us that the skin is looking mottled. Once you are seeing somebody undergo like endovascular, procedure, and the person is having livedo reticularis or a blue toe, go and pick cholesterol embolism, symptoms. So mottled skin. So skin like this, cholesterol. You see this a lot in the MBMEs, and it can also come out in our exam. So those are the causes of embolism. It could be amniotic fluid, it could be fat, it could be hair, and it could be cholesterol. So how do we make diagnosis? So the first thing is to do echo, but echo will not really help us much. Echo can show the increased pulmonary arterial pressure, right ventricular dilatation. If you do a chest X-ray, they will tell us that there's going to be enlargement of the central pulmonary artery. Yes, because if there is hypertension in the vessel, the pressure here is too much. There will be some form of, resistance to blood flow because of the increased afterload. So the central one, they are going to be enlarged, because of the resistance. So there's going to be a large central one, while the distal one will be tiny because of reduced blood flow to them. So there's distal tapering of the vessel. That's what we call pruning. If we do ECG, we're going to be seeing features of RVH, which is R wave in V1 more than 7 millimeters. The best test to make diagnosis of pulmonary hypertension, the best test is what? Right heart catheterization. Go and put in a catheter there and measure it. And it will be more than 20. If you measure the PCWP and it is less than 15, we can say that the cause is from what? Respiratory. If it's more than 15, the cause is from what? Cardiac. Do you understand that? Hello?
Yes, sir.
Yes.
So how do we treat? Give oxygen. If it's cardiac, give diuretics. Just make sure you treat the underlying problem. For some people with type 4, that they're always throwing clots, you can anticoagulate them. But we're going to talk about that one shortly. People with heart failure too, you can give digoxin just to improve their left ventricular systolic function. But most of the time they are going to ask us like treatment of the primary pH, which is the group 1. So don't forget 3 things. You are giving prostanoids, which is PGI2, prostaglandin I2, prostanoids. And what they do is to relax that vessel. So they include epoprostenol, iloprost, all those pro stuff. Anything pro, teprost, something, iloprost, epoprostenol, beraprost, pro, they will relax. So you give them. You can also give them endothelin receptor antagonist, because endothelin is a vasoconstrictor. So give something that would, oppose the effect of endothelin, bosentan, sentan, all those sentan, masentan, bonsentan, and brinsentan. Then the last one is the phosphodiesterase inhibitors. The sildenafil, the tadalafil. Those ones too can, because they are like all the CMP antagonists, so they will allow all those CMP inhibitors so that they don't antagonists so that they don't break down the CMP. So because phosphodiesterase breaks down CMP, so if you give phosphodiesterase inhibitor, you allow a lot of CMP to be in circulation, which can relax the vessels. So don't forget these 3, but don't forget the category where you use them. Group 1, group 1, group 1. Don't go and pick poster note for heart problem. To be ridiculous. So group 1, use any one of these 3. So for group 4, that's the one that they're having thromboembolism. So what? Do a surgical thromboendarterectomy. Go and remove the clot surgically is imperative. Then you must give them anticoagulants. If you cannot do surgery, because they are poor candidate, you can do balloon pulmonary angioplasty or resp. So resp is more like an analog of CGMP. I think it's one of the new drugs in town. So that one too can help them, CGMP. All right. I don't think do I have any question here? Okay, I think I do. Let's check. That's pulmonary hypertension. A 69-year-old man comes to the office due to 2 days history of increasing shortness of breath, cough, and lower extremity edema. He drinks a half of a bottle of vodka daily and has 45 back year smoking history. There is no past history of hypertension or ischemic disease. The patient has a sedentary lifestyle. This is disability at work at the age of 20. He takes some meds. He has not seen a physician in 20 years. Cardiac examination showed faint heart sound. Jugular venous pressure is 11. Lung oxygenation shows decreased breath sounds. A liver span is 18 and ascites is present. There is bilateral 3 plus lower extremity bleeding edema up to the knees. Chest X-ray shows large central pulmonary arteries without evidence of pulmonary congestion. Which of following, without evidence of vascular congestion, which of following is the most likely diagnosis? Anybody?
See, pulmonary.
So why are we picking pulmonary? What do you think this person has?
Right-sided heart failure.
Right-sided heart failure, yes. So why are we now picking pulmonary? I just want to know so that everybody
The cough, the elevated jugular venous pressure.
Yeah. So what's the likely cause? So what's the likely cause? Because you have to tie it to a cause before you can say it's pulmonary. Do you get what I'm saying? So what's the cause of the pulmonary? What do you think?
He has a 45-year peak, year path, year smoking history. That could be a risk factor.
For what? That's going to be
COPD.
So this guy is like having COPD that's caused type 3 pulmonary hypertension, which is now causing pulmonary. That's it. That is it. So let's look at this. A 42-year-old woman comes to the physician because of 2 episodes of loss of consciousness over the past week. She recovered immediately, but she was not confused following the episodes. During the past 5 months, she has also had increased shortness of breath and palpitations. She has been unable to carry out her daily activity. She reports some chest tightness that resolves with rest. She has no history of serious illness and takes no meds. She emigrated her family from India 10 years ago. Temperature is normal, pulse is elevated, irregular, blood pressure is 108/70. Examination shows jugular venous distension and PT edema below the knees. Bilateral crackles are heard at the lung bases. Cardiac examination shows accentuation and splitting of S2. There's an opening snap following a low-pitch diastolic murmur in the 5th left intercostal space at the midclavicular line. An ECG shows atrial fibrillation and right axis deviation. Which of the following is the most likely underlying mechanism of this finding? A. This.
What's the question again, please?
Increased left atrial pressure.
So what are diagnoses? So that everybody can understand.
Like congestive heart failure.
Congestive heart failure. Okay. So
Pain. Mitral stenosis.
due to mitral stenosis. That's it. So which one are we picking? Increase left
Yeah.
atrial.
Left atrial pressure.
Let's see this. A 42-year-old woman comes to the physician because of 1 year history of progressive fatigue and shortness of breath on exertion. 5 years ago, she emigrated from Eastern Europe. She has smoked 1 pack of cigarettes daily for 20 years. She has a history of meth and cocaine use, but quit 5 years ago. Vitals are normal. Physical examination shows jugular venous position 9 cm above the sternal angle. The lungs are clear to auscultation. There's a normal S1 and a loud split S2. An impulse can be felt with the fingers left of the sternum. The abdomen is soft and non-tender to palpation. The fingertips are enlarged and the nails are curved. There's a pitting edema around the ankles bilaterally. An X-ray of the chest shows pronounced central pulmonary arteries and the prominent right heart border. Which of following is most likely to confirm the diagnosis? Okay. What diagnosis are we even thinking? Anybody? What's our diagnosis of my people?
Pulmonary hypertension.
Pulmonary hypertension. So the X-ray is showing pronounced central pulmonary arteries, a prominent right heart border. That's RVH. Pulmonary hypertension. There's a split S2, pulmonary hypertension. This guy's having raised JVP. Everything is there. So what's the best next step? The best to confirm the diagnosis.
Right heart
Right heart catheterization.
Right heart catheterization. Okay. So let's take a break and we'll come back in 30 minutes.
How many minutes?
13. Hello everyone, hope we are back. So we'll continue with pulmonary embolism. And pulmonary embolism is just when we have occlusion of the pulmonary vasculature by blood clots. So most of the time they come from the deep leg veins, like the femoral vein. But they come from a DVT in the deep leg vein, like the femoral vein. But what I want to say is that the majority of the clots that dislodge to cause a PE, they come from the proximal. So if they list like different sites, iliac, femoral, popliteal, and they say which one is likely going to form a PE, we pick the iliac. The proximal ones can easily go, while most of the time the DVT comes from the lower one. So PE can lead to pulmonary infarction. So by the time the person starts having hemoptysis, it means that there's already lung infarction. It can cause right ventricular failure. So at that time, you want to thrombolize immediately and can lead to hypoxemia. So this is going to fall under what kind of pattern of hypoxemia? Anybody remembers? If somebody's having a PE, where are we going to put it?
VQ mismatch.
VQ mismatch. And what will happen to the A gradient?
It's going to
It's going to be, if we give oxygen, what will happen?
It will improve.
It will improve. No catch in all these things. Okay, so venous stasis, immobility, CHF, obesity, renal failure. It could come from endothelial injury, from trauma, from surgery, fracture, or previous DVT. So previous DVT is a risk factor for another DVT. That's very important in the algorithm. So hypercoagulability for maybe pregnancy, postpartum state. So people that just give birth, they have a very high chance of throwing a clot. Smokers, COCP use, very important. OCP can cause hypercoagulability. It can lead to hypertension. It cannot cause weight gain. Don't pick weight gain. That's a very common misconception. Don't pick weight gain for OCP. Very, very important. Coagulation disorders. People protein C, protein S, what's it called? Deficiency, factor 5 lady. they can have hypercoagulability. Malignancy, hypercoagulability. Severe burns, definitely. So we need to know the Wells criteria. Very, very important for our exam. We cannot go to that exam and we don't know Wells criteria. It's very, very dangerous. Very, very dangerous. Please, 1 minute. I beg you, please, I'll be back in like 4 minutes. There's an urgent situation I need to attend to. Thank you very much, doctors. Thank you so much. So, yes, so we need to know the Wells score. Very, very important. Very, very important. But somebody with PE, how will they present? Look for the Wells sudden onset. That's what you need in the exam. Sudden onset difficulty in breathing, PE. Sudden onset difficulty in moving the legs, stroke. All the sudden onset in medicine, we need to know, all those things because it tilts our mind to the diagnosis faster. So once we are seeing sudden onset difficulty in breathing, tachypnea, tachycardia, chest pain that is pleuritic. Even if there's fever, think of PE. Because some people will now see fever and they'll be saying, this fever now is pneumonia. And they'll be picking sputum culture. That's going to be wrong. So sudden onset difficulty in breathing, chest pain, tachycardia, tachypnea with fever. Pick anything investigating along the line of a PE. Very, very important. They can be generous enough to tell us that the person had a history of immobility. It could be that the person was immobile for 3 days, or the person had a surgery within 4 weeks. Think about a PE. If we examine, we are going to hear a loud P2, just like in pulmonary hypertension. There's going to be a loud P2. But in addition, we are going to see prominent jugular A waves. We call this something that looks like cannon waves. A waves. So A waves means that we're having like increased resistance to, atrial contraction, because if there is pulmonary embolism, the right atrium is going to be finding it very difficult to pump blood to the right ventricle then to the pulmonary vasculature. So if we do the jugular venous pulsation waves, the A waves there, which is the first one, is going to be very, very prominent. PE. So people with acute massive pulmonary embolism. So we can see somebody is having PE, but is it massive? How do we know it's massive? If you are seeing the person present with hypotension, JVD, they might not put this right bundle branch plug there. But if the person is having JVD with hypotension, that is automatically a massive pulmonary embolism. And the approach to the management is different from the other ones. If you see somebody with massive pulmonary embolism having feature of right ventricular failure, like JVD and hypertension, just immediately go and thrombolize. That is not the time to be giving heparin and be waiting. Go and thrombolize. So what is the best next step? The best next step, when we see somebody having sudden onset difficulty in breathing, tachycardia, tachypnea, pleuritic chest pain, fever, hemoptysis, is to calculate the modified Wells score in our mind. In the option, we are not going to be saying calculate Wells score. No, nobody is going to put that there. In our mind, it should be a reflex. Automatically, I want to calculate the Wells score, the modified Wells score. And what is the modified Wells score? So I have an acronym that I use. So I remember Pete Headmaster. So I used to say Deep Pete Headmaster, but it's very difficult to remember. Just say Pete Headmaster. So what's the Headmaster? The H for hemoptysis, the M for malignancy. So both of them, they get a score of 1-1 each. 1-1 each. Hemoptysis 1, malignancy 1. Then the Pete, P-I-T, the P for the previous PE and DVT. Don't forget, we have said it. Previous history of PE and DVT is a risk factor for PE. So that's the P. The I is immobilization. Have you been immobile for 3 days? Or, you had had surgery in the last 1 month or 4 weeks? You give them 1.5. Previous history of DVT, PE, we give them 1.5. PET is 1.5. Then the T is tachycardia. Heart rate more than 100, we give 1.5. So the first two are the big ones. In fact, once you can capture any one of these two, most of the time, your best next step is going to be something that we are going to talk about shortly. So what are these two? The DP. The first is what? DVT.
The signs and symptoms we are seeing, are they telling us that the person is having leg swelling, leg pain? That's likely to be a DVT. So if the person is having signs and symptoms of DVT in the presentation, you automatically award 3 points. The P is the pulmonary embolism. Does this picture fit diagnosis of PE? If yes, you assign 3. So most of the time, they might not be generous enough to put DVT symptom there, but they will put picture of PE there. Sudden onset, difficulty in breathing, chest pain. I know that this is likely to be PE. PE is most likely the clinical diagnosis. I give 3. If I now see DVT there, I give another 3. I'm getting 6. In fact, that will change the approach entirely. And we are going to talk about it shortly. No rush. Then I go further to calculate PET. Previous DVT or PE, 1.5. Immobilization, 1.5. Tachycardia, 1.5. Headmaster, hemoptysis, 1. Malignancy, 1. Now, which one am I going to use first? The one you are going to use first most of the time is the simplified clinical probability assessment scoring. So if we get a value of greater than 4, your best next step is to do a CT angio, a contrast enhanced CT scan. That is it. If it is unlikely, that is, if P is unlikely because you are getting a value of 4 and less, you do a D-dimer. But, excuse me. But if you get a value of more than 6, yes, it's fine. It's more than 4, fine, good. But when I getting a value of more than 6, like 7, I'm not going to be waiting to be doing CT angio or CT scan. I am going to immediately anticoagulate that person. First, anticoagulate first before I start now looking at investigation, because this guy is having a very, very strong evidence of pulmonary embolism. So I'm going to anticoagulate the person. But if the person is having 5, 6, in that kind of person, you might still want to do your CT scan first before you proceed. So you have calculated your Wells score. You have gotten value of 4 and less. Note the word modified Wells score, because we have Wells score and we have the modified one. The one we are using is a modified one. So you get a value of 4 or less. Your next step is to do a D-dimer. Don't forget, D-dimer have a high negative predictive value and sensitivity. If it's not there, it is not, PE. That's the meaning. It has a high negative predictive value. So if you get a D-dimer of what's it called, more than 500. So if the value is not more or equal to 500, don't think about a PE or DVT. Cancel that test. Cancel your diagnosis of PE or DVT immediately. It has a negative predictive value, a very high negative predictive value. So if your D-dimer is now more than 500, you cannot proceed to do a CT scan with contrast. If you cannot do a CT scan with contrast because maybe the person is pregnant, the person has AKI, that cannot use contrast or contrast allergy of whatsoever type, you cannot do a VQ, scan, and we know what to expect, a VQ mismatch. There's going to be reduced Q, but normal V. If normal D-dimer, that is value less than 500, PE is excluded. But if your initial score is greater than 4, like a value of 5, you need to immediately go and do a CT of the chest with contrast. And we are going to see the filling defect, just like you can see here at the bifurcation. You can see this filling defect here, this black stuff. That's a PE. This is a saddle embolus because we are seeing it at the bifurcation. So, but some contraindication of CT scan, we have talked about it, pregnancy, AKI, contrast allergy. So you might need to do a VQ scan. Pay attention to that. They give us the electrolyte value, and there's electrolyte derangement. Urea is elevated. Don't go and pick CT scan, no, please. I beg you. So ABG can show you feature of hyperventilation, which is respiratory alkalosis, because definitely they are going to be hyperventilating. And if you do a chest X-ray, it could be normal. Most of the time, it will be normal, but they can see like atelectasis, pleural effusion, particularly the exudative pleural effusion. They can have Hampton hump, which is wedge-shaped infarct, a Westermarck sign, which is collapse of the lungs. A lot of signs, you see, Let me show us. But we don't need to be memorizing science. This is not stuff exam. It's not exam of who gets stuff passed. There are so many stuffy people that don't still do well. So it's just about how much you can think. You know, that is it. It's not stuff. You can have all the stuff in the world and still like not have anything to show for it. So if we look at this image here, you know, you can see this wedge shape infarct. They take the shape of the lungs, you know, wedge shape infarct here. This is the Hampton hump. PE, you know, we can see the focal like distal oligemia. You can see this white stuff here, this distal area, you know, spreading downwards like that. So that is a what's it called, the Westermarck sign. That's the oligemia because of obstruction to blood flow within the pulmonary vessels. So those are what we find in PE. Trust me, it will not get to that level in that exam. They are not that wicked and be giving us anti-number. We say we should be making diagnosis of PE. It's very unlikely. You know, the history will have, you know, painted everything. So if you do ECG, they can have sinus tachycardia, but sometimes they can have a classic triad of the X margin white sign, S1, Q3, T3. Don't go and be memorizing this thing. Don't forget, USMLE step 2 is not a syndromic stuff. It's not exam of quiz club. Nobody's going to be asking like S1, Q3. All these things are very rare. So they are not common. They ask common things, you know. So some people, if they forget S1, Q3, they will start panicking. I don't know stuff. But step 2 is not about stuff. Trust me, it's not all about stuff. So so S wave in lead 1, Q wave in lead 3, and inverted T in lead 3. We can do a lower extremity venous ultrasound, which is going to pick the DVT, which can be the cause. So what do? You know, if you are not getting a value of more than 6, you might want to start with maybe your D-dimer or the CT scan, depending. But if you get a value of more than 6, you start with the anticoagulation before you now start investigating. But after you have done investigation and, you know, you are seeing features of PE, so what do you do to treat? You want to anticoagulate. I want to give a parry, right? I want to do DOACs, depending on the circumstance of that patient. But before you start heparin, you want to evaluate, is there any contraindication to anticoagulation? Maybe this person had a stroke recently, or maybe there's, you know, a lot of things. Maybe there's GI bleeding, you know, that I thought they listed some of the risk factors, the contraindications. Yeah, GI bleeding, hemorrhagic stroke, recent surgery, aortic dissection. All these kind of people now, we cannot give them anticoagulation. You cannot do that. So what do? You want to place in IVC filter. Please have this at the back of your mind. Don't always say that, okay, whenever I see PE, it is always anticoagulation. Sometimes you might need to just place in a filter. So if there's contraindication to anticoagulation, you can use a filter. If you have used anticoagulation to the maximum dose and it's not working, place in a filter. Very important. So if you've done your diagnostic evaluation, PE is excluded, don't do anything. If you don't have diagnostic evaluation, there's contraindication to anticoagulation, put in a filter. If you have done your testing for PE, there is no contraindication to anticoagulation, and you know that, from all the investigation I've done, this is likely to be PE, just start your, anticoagulation. Very, very important. So this one is just following what I've said initially. If you have a very high clinical suspicion, maybe you get a value of 7 and above, you don't even wait till you start investigation. You quickly start empiric anticoagulation. 7 and above, empiric anticoagulation. But if it's like 5 or 6, you might want to go and do diagnostic evaluation, which is what? What diagnostic evaluation are we going to pick? 5 or 6? CT. So we do our CT, and if you confirm the PE, start your anticoagulation. If there is no PE, discontinue. Don't give anticoagulation, or if you have started before, discontinue it. It is as simple as that. So somebody with acute PE, just to give unfractionated heparin, you can use low molecular weight, except the person has kidney problem, or you can use DOACs. But if you ask me, which one am I going to pick? Me, I will pick DOACs because I don't have to be monitoring. It is very good. And people with renal failure, you cannot use unfractionated in them. you cannot use low molecular weight. So in them, just give apixaban or give unfractionated heparin. So for the chronic, you can also use low molecular weight or DOACs or warfarin, but the best is to give DOACs. IVC filter, I have talked about that. People that they have contraindication to anticoagulation and they have a PE, give them IVC filter. If the patient is also experiencing recurrent emboli and the person is on therapeutic dose, you have given the normal dose of the anticoagulant and it's not still working, put in a IVC filter. The person having massive PE, you are seeing evidence of right heart failure, hypotension, elevated JVP, right ventricular strain, or more, due to like SADU, pulmonary embolism, just go and thrombolize. Don't start and be picking DOACs. Go and thrombolize immediately. So you might want to consider DVT prophylaxis for all patients that are immobile. The most effective one is to encourage them to ambulate early. Place them on subcutaneous heparin, Clexane, or low dose, low molecular weight heparin. And you can also, wear, the test stocking and the likes. Let me see if you have a question here. We should. P is too important for that exam. So a 56-year-old obese man comes to the emergency department complaining of acute onset chest neural bread. He twisted his ankle 5 days ago and he had limited mobility since. Other medical problems include type 2 DM, hypertension, CKD, right knee, osteoarthritis. His medication includes insulin, amlodipine, low-dose aspirin. Blood pressure is 110, pulse is 110, hemoglobin is 11.2, platelets is 230K. The estimated GFR is 20. Ventilation perfusion scan shows right upper lobe perfusion defect with good ventilation. Which of the following is the best initial treatment for this patient?
Yeah, the entire question, part of the question is hidden from me. Maybe if you can adjust it a little bit. I don't know.
Are you sure? Like everything is kind of showing here.
It's in there. Okay, yeah, it has happened before. Thank you very much. Everything is here too.
Okay.
T.
What?
Unfractionated heparin.
Unfractionated heparin. Why are we picking unfractionated heparin?
Patient has PE.
Okay. So why not enoxaparin? Why not warfarin? Why not?
That's renal failure. GFR is low.
GFR is low. There's renal failure. So let's see this. A 69-year-old man undergoes urgent laparotomy due to strangulated inguinal hernia, necessitating resection of 40 cm of the small bowel. On the morning of the 4th postoperative day, he falls out while getting out of bed. Afterwards, the patient is irresponsive or confused. His speech is incoherent and he cannot remember what happened. Blood pressure is 83/55, pulse is 130, respiration is 28. Finger oxygen saturation cannot be obtained due to steady pulse. Examination shows decreased breath sound at the lung basis. Neck vein appear distended. Abdomen is soft, non-distended. Surgical size is unremarkable. ECG shows sinus tachycardia and a new right bundle block. And non-specific T-wave changes. Immediate resuscitation with wide open IV fluid is ineffective. Shortly after, the patient shortly after the patient pupils begin to dilate. His pulse decreased to 35 and he became unresponsive. He eventually dies despite resuscitative effort. Which of following is the most likely cause of the patient death? Anybody?
Pulmonary embolism.
My people, what do you want to do for this patient?
This is massive pulmonary embolism. You want to embolize.
You want to embolize. You want to what? You want to what?
Thrombolysis.
Don't let us go and embolize.
You are not thrombolysis. Thrombolysis.
We want to trombolize the patient. That's very good. So please expect questions like that in our exam. Very important stuff. Know the algorithm. Know when to trombolize. Know when to anticoagulate. Know when to put IVC filter. Know when to calculate your well score. Know what to do after you get your well score. Very important. So, a 53-year-old woman is brought to the emergency department after she collapsed suddenly while standing and lost consciousness for about 3 minutes. She recovered spontaneously, but she is very weak and dyspneic. She also reports left-sided chest pain. There was no tonic-clonic activity or incontinence. The patient was recently diagnosed with colon cancer on a routine colonoscopy and is scheduled to undergo surgical resection. Her only other medical problem is hypertension, but she has not been compliant with her medication. Her blood pressure is 86, pulse is 120 and regular. Pulse oximetry shows 80% on room hair. She's diaphoretic and tachypneic. Jugular venous pressure is 13. Lungs are clear to auscultation. Further workup in this patient will most likely show which of the following. What do we think?
I'm thinking F, right ventricular
Right
dysfunction.
ventricular dysfunction. This is a candidate for thrombolysis as well. You can see the hypotension. We can see the raised JVP. So this is sudden. It's happening suddenly. Left-sided chest pain, dyspnea. And she has been diagnosed of cancer. So that's the cause. So that's the way to look at PE. Very simple. So moving on to something that is a very little bit complicated, but we'll try to make it easy, and that is solitary pulmonary nodule. So most of the time we find all this. So for which to say that something is a nodule, it has to be less than 3 centimeter, or it has to be like less than 30 millimeter. Once it's more than that, it is a mass. It is no longer a nodule, it is a mass. So usually we find that on X-ray mistakenly, accidentally, and sometimes most of the time they are asymptomatic, or sometimes they can have some symptoms. They can have chronic cough, dyspnea, not specific stuff. So, but we might want to ask them about, if you are taking the history, ask them, are you a smoker? Because that can, highly suggest if that is a cancer or not. Are you exposed to anything? Do you go and be exploring caves? Histoplasmosis. Where do you live? Southwestern people that, I don't know. I'm not familiar with the geographics, in the US, but people that live there, you can know what this is. But trust me, USML is not wicked, that they will be painting the scenario to only favor people that know geography. No. You'll be able to pick it, even if you don't know the geographic basis, but you can pick the clinical stuff. You'll be able to, you'll still be fine. So don't worry, because I've seen so many people, what they'll be cramming is Ohio, Mexico, Virginia, Michigan. That's where they are cramming. You wouldn't need all those things, trust me. They can even put it there to deceive you. So work with your clinical findings, your imaging findings, rather than geographic location. So, but your exposure can also give a hint about what is happening to the patient. So people that recently traveled from TB endemic region, coming from Cambodia, India, Nigeria, Ghana, think of TB. So people that are coming from the southwestern United States, think about coccidioidomycosis. So people from Ohio River Valley, think about histo and blastomycin. Trust me, I don't know all this. I can know Ohio, but southwestern US states, I did not. Someone wants to give an example of southwestern. Anybody knows? Because I know many people here are from the US. Anybody knows an example of southwestern US states? Okay, nobody knows. We move on. So we don't need it. So now, what is the best next step? Long nodule that was discovered. Best next step, CT scan of the chest. So if the physician discovered a nodule on another modality, maybe they did X-ray, the best next step is always to look at that lesion clearly with a CT scan. Don't ever forget that. Do a non-contrast. Don't forget, when we are doing PE, we choose a contrast. When you want to look at a stone, you do a non-contrast. When you want to look at a nodule, you do a non-contrast. Very important stuff. A non-contrast CT scan of the chest to look at the nodule. Well, okay, we have seen done, X-ray, but let's have a good look at what is happening. We obtain a CT scan of the chest. Some people will still be arguing, maybe they have done X-ray. Why are we still picking CT? Trust me, CT is what you have to pick to look at it well. So sometimes it could be like a benign lesion. And what are we going to see? So it's going to have like popcorn calcification, fats. So I have some notes there, which are popcorn calcifications are multiple punctate calcifications within a nodule. So it could be hematoma, amatoma rather, and they can also have fat deposits. So all those things are features of benign lesions, probably like a granuloma or hematoma. So you don't need to do any further evaluation once you are seeing features of benign event. If what we are seeing after we have done our imaging, is not looking benign, the best thing you want to do is to order previous imaging that have been done. Oh, please, this person, has it done a previous CT? Let us compare. So we look at it. We look at the old and we look at the new. So this lesion we are seeing, is it present in the previous CT? If it's present in this previous CT, it means it is an old nodule. So it's not likely. It's not likely to be like a cancer. It has been there. So if it's stable, it's not changing, within like the size is not increasing, you can say that it is benign. So old nodule that has no changes in size, in pattern, is likely to be benign. So you don't need to do any further evaluation. But if you request for previous CT, and the nodule is not there, so it means that nodule we are seeing in that current imaging is a new lesion. Or maybe in the previous CT, the nodule is there. But now, the one we are seeing now is bigger than what is in the previous CT. We want to rule out malignancy. Very, very important. So now, to now know if this is a malignancy or not, you have to characterize what you are seeing on that CT with your clinical history that you have taken. So what are the things we are working with? This is it. So what is the diameter? That's number one. Is it less than 8 or more than 20? If it's 20 or more, that is high risk. If it's less than 8, that is low risk. More than 20, high. Less than 8, low. If it's in between, intermediate. How old are you? That's the next thing. What is the age? So is this person more than 60? So you quickly look at the age in the question. Is this person more than 60? Yes. Is it less than 45? Yes. Less than 45, it is low risk for malignancy. More than 60, it is high risk for malignancy. Are you a smoker? Yes, high risk. You have never smoked before? Yes, low risk. Okay. The person is a smoker, but the person stopped less than 5 years ago, high risk. The person stopped more than 15 years ago, low risk. So there are two things about smoking. Are you a smoker? If you have stopped, when did you stop? Then the next is to look at the characteristics of the nodule. Is it smooth? If it's smooth, benign, low risk. If it's high, that is, you are seeing coronal radiata. You are seeing like projections from the nodule like this. Projection like this. Coronal radiata. Or speculated, the same thing. Speckles from it. Malignancy. If it's just scallop border, think about intermediate. Calcification. Popcorn calcification. We have said this already. Fat popcorn calcification is benign. If there's no calcification, it's very, very common in malignant. Malignant also have high tendency of settling in the upper lobe. They are usually on the upper lobe of the lung. Very, very important. So look at the age, look at the diameter, look at the nodule characteristics. Then you ask about, smoking. Are you a smoker? If you have stopped, when did you stop? So age 60, 45, diameter 8, 20, nodule characteristics, is it speculated, coronal radiata, or popcorn? Are you a smoker? Yes or no? Then when did you stop? You are using 15 years and 5 years. Let's familiarize ourselves with the table. It's going to be very helpful. So, you now stratify. So you calculated everything. You are now getting 3 or more. So the side where you get 3 or more, that's what you are going to be working with. So if I get 3 or more in under high, so that means that person has a high risk of having a malignancy. I go and do surgical resection. So if it's under low, risk, I can just do serial CT scan for 2 to 3 years and I stop. That's all. If the person has intermediate, then the best next step is now to stratify according to the size. If it's intermediate, the next thing is now to stratify according to the size. So if the size is more than 8, then you need to do something active. You do a PET or you go and do a biopsy. Please, a biopsy is different from surgical resection. Don't go and confuse it too. What you are just doing is just biopsy to obtain a sample. You are not doing like excision biopsy to remove everything. Just take a small sample to go and do histology. Resection means you are excised, you are removing everything. Surgical resection, please pay attention to that. So if the size is 8 and more, go and do a PET scan because that's a very high risk for malignancy. Despite being an intermediate stuff, there's still high risk. So you go and do a PET scan and biopsy to see whatever is there. If you think it's malignancy, go and remove it completely. If it's not malignancy, but because of the fact that it's 8, do your CT scan serial for like 2 to 3 years. If it's between 5 to 7, don't do PET or biopsy. Just go and do serial imaging for 2 to 3 years. But if it's less than or equal to 4, so you can now, do your like stratification again to just see like the other features. If it's falling between like high risk, you can now do like serial. But if you think it's not something to worry about, just do like no further, evaluation. Most of the time, it will not really get to this down part. You will have stopped somewhere here. We should not worry about that. So high risk, go and reset immediately. Intermediate, that's do what? Go and do what? Biopsy or what? PET scan if it's intermediate. PET scan or biopsy, especially if it's more than 8 millimeter. So let us look at some questions here to see, A previously healthy 42-year-old man is brought to the emergency department 1 hour after he was involved in a motor vehicle collision. He's conscious. He smoked 1 pack of cigarettes daily for 16 years, but quit 8 years ago. Physical examination shows several ecchymosis around the trunk and abdomen. The abdomen is soft, but there's tenderness to palpation of the right upper quadrant without guarding or rebound. Vital signs are within normal limits. An X-ray of the chest shows no fracture. A 10 millimeter solid pulmonary nodule is present in the central portion of the upper right lung field. No previous X-ray of the patient is available. A CT scan of the chest is performed and shows that the nodule has a regular scalloped border. Which of the following is the most appropriate next step in the management of this patient pulmonary nodule? Please let us start writing. The age of this patient, what is it? 42. So where does it fall? Is it high, intermediate, or low? 42 years.
Low.
Low. So
Yes.
after the age, the next thing is to look at what? We can look at
Smoking history.
smoking history. Okay, we want to go to smoking history. So is this person a smoker? Yes.
Yeah.
Yes.
So that is
Yes.
So that can be intermediate or high too. That can be intermediate or high. Okay. As this person has quit, right? So this person quit 8 years ago. Is that high, intermediate, or low?
Intermediate.
Intermediate.
So we can say that we have like 2 intermediate now. 1 low, 2 intermediate. Good. Now we have to look at the nodule characteristics, right?
Mm-hmm.
Yes.
So it is scalloped and irregular. So what is that?
Intermediate.
We have 3 intermediate now. Then the last one is to look at if there's any classification or, did they talk about that? They didn't. I don't think so.
No.
So most of the thing is following under intermediate risk.
What
do we do?
size? The size, 10 millimeter.
Okay, thank you.
Yeah.
The size. So what's that?
Intermediate.
Intermediate. What do we do for this patient? If it's intermediate, what's the best next step to do?
PET or biopsy.
Okay, you are right. But let's still follow the algorithm we've said. So once it is intermediate, what is the next thing we say we are going to do?
Biopsy.
No.
No, determine the nodule size.
You now determine the
Which,
size. You stratify according to the size. And we are working with 4 and 8, right? So this one is more than 8. This is 10. So what are we going to do?
yes.
Pet.
Or PET.
Pet or what?
Biopsy.
You can see that there's no biopsy there. They can never put biopsy.
Mhm.
So go and pick our pet. It is as simple as that. There's no need to panic. You know what you are picking. You know why you are picking it. So a 61-year-old man comes to the physician for an examination prior to scheduled cholecystectomy. He has hypertension treated with hydrochlorothiazide. His mother had chronic granulomatous disease of the lung. He works in a glass manufacturing plant. He has smoked 2 packs of cigarette daily for 38 years. Vitals are within normal limit. Examination shows no abnormality. Lab studies are within reference range. An X-ray of the image is shown. Oh my God. Do I have this X-ray? Yes, I think I do. Which of following is the most appropriate next step in the management? Let me see. Oh my God. I did not save the. Oh God. I thought I did not attach it. Okay, now I know what the X-ray is showing. So the X-ray is showing a nodule, in the lung. There's a small nodule in the lung. So what are we going to do for this patient?
Request previous chest X-ray.
God bless you. You request a previous chest X-ray. That is what you are going to do. Very, very important stuff. You request a previous, chest X-ray. Very important to see, to compare, if there's any change or not. Very important. All right. Thank you very much. So, it could be this is the stuff we are looking for. Let me see. So I can just show us what the nodule looks like. I think this should be it. Okay, no, this is the algorithm. This is the algorithm. That's fine. We already know the algorithm. Okay.
Please, can I ask you a question, please?
Yes, I'm with you.
Okay. So what if the question, they give us someone that quit about 2 years ago, and the borders are irregular and no calcification. So what do we do?
So it's not yet complete. So we look at the size too, and we look at the nodule size. Is it speculated or not? The thing is, I don't want you to create a situation that will confuse us. The thing is, the question will always give you a presentation that you'll be able to stratify. Trust me, you'll be able to stratify. Just go for the one that has the highest number in terms of the characteristics. Most of the time, the one that have 3. Most of the time, the one that have 3. Once you can pick 3 in a category, that's the category that you should pick. So you have looked at the diameter, you have looked at the age, smoking history, if the person has stopped, characteristics and classification. So the one that have the highest number, that's the one that you're going to stick with. Then you proceed along that line. Do you understand?
Okay.
So you don't worry. You don't worry. Trust me. Once solve questions, you will see it. You will definitely be able to stratify. They won't put you in a tight situation. No, they won't do that. Yeah. All right. So moving on to lung cancer. So lung cancer is the leading cause of cancer death in the US, and risk factors include smoking, except the bronchoalveolar carcinoma, which is a type of adenocarcinoma, radon exposure, and asbestos. We have said it that asbestos, the commonest cancer I share with asbestos is what?
Bronchogenic cancer.
Bronchogenic cancer. But it is the only cause of mesothelioma. That's what we say. So we need to know lung cancer. It's inevitable. It is inevitable to come. It will come. Of course, look at what they said now. They said it's the leading cause of death. Do you now think that they will now like forget to put the leading cause of death in their country? They will fail to put that kind of question in our exam. It's not possible, because we need to know ways to tackle it. We are going to see it, So what are the types? we have the small cell, we have the adeno, we have the squamous, we have the large, and the bronchial carcinoid. So the small cell is separated from the other ones because this guy is different. So mind you, small cells are shared with smoking, but small cell is not the commonest in people that are smoking. The commonest in people that are smoking is squamous cell. So if you find yourself in a situation that the only thing you can use to pick it is that smoking, epidemiologically, just go and pick squamous cell. Don't forget it. Unless you see something distinctive that separates them, that, oh, this thing is pointing towards small cell. Let me pick small cell. So small cell is central. It's not peripheral. It's central in location. And is highly correlated with cigarette exposure. Yes. They are undifferentiated. It is anaplastic. They don't look anything like the cells they are coming from. In fact, when you biopsy, what you are going to be seeing is neuroendocrine cells that you call the Kochiski cells. They are small round dark blue cells. So they show us histology, and we are seeing small round dark blue cell. Let's go and pick squamous, small cell, or it could be bronchial, bronchocarcinoid, cancer too, but we separate them. So small cell is going to stain positive for chromogranin A, for neuron-specific enolase and synaptophysin. Yeah. Now, what are the other things they are going to put there for small cell? Most of the time, small cell is metastatic. It will have gone far before they pick it. It will have gone to BLB, the brain, the liver, and the bone. Very important stuff. It will have gone to the brain, the liver, and the bone. So, what are the paraneoplastic syndrome that they like putting with small cell? I like remembering the Hayes, ADH, ACTH. Dr. Abande will have this. I know this one is like basic stuff, from step one. So ACTH, Cushing syndrome, and inappropriate secretion of ADH, and of course, so please let us learn ADH very well. Let us know osmolarity, all those electrolyte changes, urinary, all those because they might not go and be putting what's the diagnosis alone. No, they might be asking you like what's the changes, some sodium, urine sodium. Please, let's go and learn all those things. Very, very important. We have to know it. So, and also antibodies against presynaptic calcium channels, they can have that, which is Lambert-Eaton syndrome. So, of course, once you see somebody with small cell cancer, one of the paraneoplastic problems they can have is Lambert-Eaton, and we know how to distinguish Lambert-Eaton from Myasthenia gravis. Dr. Babande will have exhausted that discussion. They can also have some neurologic problems, paraneoplastic encephalitis, paraneoplastic myelitis. We know all those things. So they just have sudden onset difficulty in walking, bladder control is problematic, bowel control is problematic. Think about paraneoplastic myelitis. Sudden onset difficulty, like they just start having memory loss, personality changes, psychosis. Think about paraneoplastic encephalitis. Somebody with squamous cell cancer. Most of the time, it is, inoperable. You can't operate. So what you just do is just to give your chemo. Just give them chemo and add radio. Probably if they are having like metastasis to the what's it called, to the bone. So you can give, radio to take care of the pain. But radio can also be very good for primary tumor at early stage and to also like to palliate. If it goes to the brain, please don't be scared to give radio to the brain. No. They can give radio for brain met too. Very important. And chemotherapy is usually the mainstay because most of the time they will have gone far. They will have gone far. So metastatic disease, just give a chemo. Especially those plastin, cisplatin and the like. That's what they use. So that's that about small cell or hot cell. You see the small round blue tumor. Let us see an histology. And small round blue tumor of small cell carcinoma. Let's just see, in case it's just short in our exam so that we know what it looks like. So look at this now. This is it here. So you can see all this small round blue, tumor here. Yeah, this is another one. Small round blue tumor. Once you see this histology, don't panic. Let's just pick small cell carcinoma easily. So adenocarcinoma, this is the one that is peripheral and is not shared with smoking. In fact, it's common in females. Yeah, that are non-smoking. They're the ones that have adenocarcinoma. And they usually have this activating mutation involving the KRAS, EGFR, and ALK. KRAS, EGFR, and ALK mutation. It's associated with finger clubbing. That is the paraneoplastic manifestation. Just like as small cells are associated with Cushing syndrome and syndrome of inappropriate secretion of ADH with Lambert-Eaton. Adenocarcinoma is finger clubbing. And there's a there's a type that is just inside too. It has not breached the basement membrane. We call that the brachioalveolar subtype. It's not very important. But what do we see on histology? Once we see the word gland, once they tell us that they are like glands, on histology that stains mucin, just know that is adenocarcinoma they are talking about. Adenocarcinoma. So very common in people that are not smoking, and it has a peripheral location. For the squamous cell, they just tell us that the person is having cavities. Once you see cavity, and the person is taking cigarette, smoker, cavities, think about squamous cell. It has a paraneoplastic manifestation, and that is what release of PTHRP. Please, this is PTH related peptide. Don't let us go and be picking PTH. So parathyroid hormone related peptide, that is it. It's also associated with smoking, like we said. And on histology, we are going to see the keratin pills. That's what you need. Anything keratin, squamous cell. Keratin anywhere is squamous cell. Cavitation, squamous cell. Then the last cell, it's more like we are going to be giant cells on histology. Giant cells, large cells on histology. It is peripheral, just like adenocarcinoma. You see it at the peripheral part of the lungs. It has a poor prognosis because it's very difficult to it doesn't typically respond to chemo, so we have to go and remove it surgically. The bronchial carcinoid, most of the time, this one is going to be causing obstruction. It causes obstruction in the lungs, so they can tell us that the person is having recurrent pneumonia, recurrent infection. It's due to the obstruction. Sometimes it can cause carcinoid syndrome, in which the person is going to be having features of, release of histamine, serotonin, and all those things. So they can be having flushing, diarrhea, redness of the face, wheezing, and all those things. So think about somebody having flushing, diarrhea, wheezing. Think about the bronchial carcinoid tumor. So we see the small round blue cells too, just like small cell cancer. So yeah, so these are the cancers. You can see that this one is central, so it's likely to be small cell or squamous cell carcinoma. Image C is adeno. Let me see. We don't have image C here. Okay, yeah, you can see this is like glandular appearance. So this is adeno. This is small round blue cell, so this should be like maybe squamous. Let me see. Let's track it. So no, histology shows histology. D is squamous cell, actually. We are wrong. Okay, so this is what I missed. So this part, so these are like the one for squamous cell histology. But don't worry, from the clinical presentation, we'll be able to figure out what is actually, happening there. So we don't have the one for small cell here. All right. So what are the complications of lung cancer? What complications do we expect? Very, very important. But before we get to complication, we need to talk about the presentation. So they can have cough. Dyspnea, hemoptysis, weight loss. Very important. Weight loss. Weight loss is a very good clincher for malignancy. Whenever you see weight loss in the question, think about malignancy. Weight loss, cough, hemoptysis. if there's obstruction of the airway, they can have wheezing, recurrent pneumonia due to obstruction, and they can have some complications. And the first is the superior sulcus one. So especially the ones that they sit at the upper lobe, we call that the pancreas tumor. So they can have some complication. They can compress on the nearby brachial plexus. And one thing you are going to see whenever there's compression of brachial plexus is shoulder pain. Look for it. Once you see it, don't panic. Just go and pick brachial plexus compression. That's how you are going to see it. Shoulder pain, shoulder pain, shoulder pain. So shoulder pain or hand pain, it is due to brachial plexus compression. Superior sulcus tumor. They could compress on the nearby paravertebral sympathetic chain and they can have ulnar syndrome. When they compress on the sympathetic nerves, which runs through the neck, we should not worry about the anatomy now. Just know that in the neck, towards the T1, C8, that area is very close to the tip of the lung. So they can easily get compressed, and the person is going to be having features of ulnar syndrome, which is what? Meiosis, ptosis, and anhidrosis. They can have superior vena cava syndrome. Don't joke with this. So there's obstruction of the SVC, and they can have, SVC enlargement, facial swelling, redness of the face. But one thing about superior vena cava syndrome is that it's going to be bilateral. But if it's compression of the brachio, cephalic trunk, brachiocephalic vein, rather, not trunk. Oh, there's a difference between trunk and vein. If it's due to compression of brachiocephalic vein, then it's going to be unilateral, But if it's SVC, both of the face is going to be swollen, venous engagement in both sides. Everywhere is going to be red. It could be compressing on the recurrent laryngeal nerve and they can have hoarseness. So this one now is going to be like SVC compression, And we also know the paraneoplastic syndromes, ACTH for small cell, SIDH for small cell, hypercalcemia due to PTH releasing peptide for squamous cell, gynecomastia for large cell because it causes big things, so it can cause big breast. Finger clubbing for which one? Which one did you say is actually finger clubbing?
Adenocarcinoma.
Adenocarcinoma. Thank you. So, peripheral neuropathy. So most of the nervous problems, small cell. Most of the nervous problems, small cell. Migrating thrombophlebitis, adeno. Why? Adeno is mucinous. Anything that secretes mucin, they can be causing like, all this inflammation of the veins and the likes. And they can also be forming clots, So they can have migratory thrombophlebitis, adenocarcinoma. They can have non-bacterial verrucous endocarditis and adenocarcinoma because of the mucin, And all of them can cause anemia, DIC, eosinophilia, thrombocytosis, hypercoagulability, and acanthosis nigricans. So the best initial test is to do a X-ray or CT, whatever one you can afford, And of course, if the imaging results showcase that there's a high risk for malignancy, you need to go and do a CT guided, biopsy for peripheral lesions or bronchoscopy for central lesion. This is another place they will wait for us. So people will be confused. What do I pick? So bronchoscopy if it's central. So it means that once you are seeing it very close to the hilar region, just go and do bronchoscopy because it's very easy to approach it there. If it's somewhere here now, want to biopsy, just go through this place and do your bronchoscopy and take it. But if it's here, that's peripheral. So go from the side by doing a CT guided, biopsy. So very important. If it's peripheral, do your fine needle aspiration using CT guidance. If it's central, do your biopsy or brushing with your bronchoscopy. Very, very important stuff. After you have done your histology and you have seen it, you now have to stage. That's the next thing. Even if it's GI cancer, you have done your diagnosis. The next is you want to stage. So do your PET or your CT. PET is very good. If you can do PET, they should do it. If there's no PET, do your CT scan. So I don't think we should worry ourselves because most of the time it's going to be small cell that we are going to be seeing. So once it's small cell, don't forget it's usually like it will have metastasized. So just offer chemotherapy, systemic therapy. Chemo, most of the time, they are going to be fine. Chemo, most of the time. Once you are seeing small cell, lung cancer, just chemo, just give chemo. Don't worry about it. Chemo will do it. So you can offer them targeted therapy too. For example, people with adenocarcinoma that is due to EGFR or ALK translocation. It can give some target therapy that can stop all this, mutation. And they can also use immunotherapy, which is like all these checkpoint inhibitors. We don't need to cram any of this. They're not going to ask us. Don't worry about it. So let's talk about pneumonia. Let me see if I have any question on lung cancer. I have any question on lung cancer? Okay. A 43-year-old man comes to the office due to several weeks of nagging, left-sided chest pain that worsens with deep inspiration. He has also had a progressive non-productive cough and mild dyspnea. The patient denies fever or chills. He's diagnosed with Hodgkin lymphoma in his early 20s and was treated with chemotherapy and radiation. Blood pressure is 144 and pulse is 92. The patient appears thin. Examination is normal. Chest X-ray is shown in the image below. Which of following is the most likely cause of this patient's current manifestation? Let me show us the X-ray. Can we see this X-ray?
Yes.
So what do we think?